seventh meeting of the Global Cosmetic Surgery. Thanks to all these luminaries who are on the same screen as I am at this moment. And once again, thank you so much for giving us the opportunity to put together an aesthetic masterclass, this time from the masters. This one is called the 5 Minutes Pearls Medley, which means that everyone's going to come and talk about the 5 tips which you can take to your clinics. And we look forward to you learning and us learning as well as we interact with you going forwards. Over to Tanuj.
Thank you, Debraj. It is our absolute honor as Global Cosmetic Surgery to host this meeting today. When we were brainstorming the idea for this conference, we really were a little selfish. We wanted to create a venue where we could hear lectures that actually are interesting to us. We know that people will have lecture fatigue and conference fatigue, but if everyone is forced to distill down all of their knowledge to 5 minutes, it can become a very high yield session. And so I'm personally looking forward to this conference, and I can't thank the speakers and the moderators and the chairs enough, because we're going to have a wonderful couple of hours ahead of us here. And this is all being recorded, so this will be something that in the future, other physicians in training and physicians will be able to enjoy as well. I want to also take a moment to thank all of the heads of various organizations around the world. I think that as we are moving into the 21st century, it's obvious that all the specialties come together more than we're separate. And so today we have oculofacial plastic surgeons, we have dermatologists, we have facial plastic surgeons, we have oromaxillofacial surgeons, we have ophthalmologists, we have plastic surgeons, and we have aesthetic physicians all together here, all in the common pursuit of learning, which is really why we all went into medicine in the first place, is because we're curious, we want to learn, and we want to make a difference for our patients. So that being said, I just want to take a moment to thank the sponsors. We'll hear from QR678 at a later point. Avia Skincare is one of the sponsors that helped to fund the meeting. They wanted me to just let everyone know that there is a possibility to combine Ayurvedic medicine and Western medical grade skincare together, which is what Avia Skincare is. So that all being said, I'd like to go ahead and introduce the first luminary, who's the head of Sopanope, Dr. Jorge Corona, my good friend, just 300 miles north of me in Dallas. Jorge, thank you for joining us. We'd love to hear from you and your organization.
Jorge, you're on mute.
Can you hear me now?
Yes, yes.
Perfect. Well, thank you so much for the invitation. It's just an honor on behalf of Sopanop. Tanuj, when we hear about the invitation, we couldn't be happier. Sopanop is a society that represents the Pan American oculoplastics doctors. We cover over 600,000 people in all of the Americas. And being at this event, the Global Cosmetic Surgery, is just an honor for us. Putting a meeting like this one, it's just an incredible effort. We just finished a meeting with just a couple of people here in the mountains in Colorado, and I cannot commend you enough for this effort. Sopanop is going to have next year a live meeting that we're going to be in Riviera Maya, and we hope that most of you can join us there, because it's going to be in the sunshine of Mexico, and we're going to be able to be with you guys in the same setting and not be worried about COVID anymore. So thank you again, Tanuj, and I'm looking forward to hearing all the speakers, moderators, and couldn't be happier to be here. Thank you so much.
Wonderful. Well, thank you so much, Jorge. Next, we'd like to introduce Dr. Kevin Duplechain, who is a cosmetic surgeon in Louisiana and is the current president of the American Academy of Cosmetic Surgery. We're so pleased to have you here, Kevin. We'd love to hear from you and the American Academy of Cosmetic Surgery.
Great. Thanks, Tanuj and Debraj. It's nice to see you guys. We work out on some committees within the Academy. It's a little early. I'm in Las Vegas at a users meeting, so I got up a little early and had coffee. It's a real honor and a chance to talk a little bit about the Academy. There are many people on this call that are good friends of mine that we've all served together. The Academy's been around for around 40 years. It was founded by plastic surgeon Dr. Richard Webster, who was a Harvard plastic surgeon. And our goal is to provide safe and good education for everyone that's interested. We are well represented throughout the country and really throughout the world. We have a strong voice in the AMA, and so our needs and interests within organized medicine are very, very well respected. We offer a number of fellowships, both in general cosmetic surgery and facial cosmetic surgery, and that's a pathway to board certification by the American Board of Facial Cosmetic Surgery and the American Board of Cosmetic Surgery. The Academy is, it's so much more than just a meeting. There are many, many educational events, but we are a home for people that are interested in being part of cosmetic surgery and that are interested in learning about cosmetic surgery, just like today. It's just such an honor to be part of this. Next year, our meeting will be in San Diego. We just finished our national meeting here. Throughout the year, we offer a number of different educational events, including a cadaver workshop, usually within our general meeting every year. It either usually face or body, and we alternate. So we have many, many offerings. So if you're not familiar with the American Academy of Cosmetic Surgery, go to cosmeticsurgery.org and take a look. Give us a chance. So give us a chance to prove to you that you've made a good choice if you decide to join us. Thank you guys so much, and we'll have a great meeting this morning.
Thank you so much, Kevin. Next, I'd like to introduce Dr. Mo Banky, who is a good friend of ours. Also, there's so many overlapping roles here. We're all friends from the American Academy of Cosmetic Surgery. He's the current president of the American Board of Cosmetic Surgery. Dr. Banky, thank you for joining us.
Well, welcome from Providence, Rhode Island, and Brown University. It's an honor to be here. Thank you for inviting me. I have to commend the organizers, Tanuj, Debraj, and Monica, in putting together an outstanding format. Not only just outstanding presentation, but just the format is incredible, giving it a short glimpse at what's important and just leaving the rest out. With that in mind, I am the president, as you mentioned, of the American Board of Cosmetic Surgery, and I also serve as a treasurer of American Academy of Cosmetic Surgery. So just to put it in perspective, a quick summary, the American Academy of Cosmetic Surgery that Dr. Duplichin alluded to, its role, it's primarily involved with education. As part of our education arm, we do have the fellowships that are accredited by American Academy of Cosmetic Surgery. They entail 1 year, fully fully encompassing all aspects of cosmetic surgery, at which point, upon completion, the fellows are required to take the American Board of Cosmetic Surgery, and that is an examination that's administered in writing, and then that's followed in a couple of months by challenging the oral component. We have about 300 plus diplomates of the board. They're throughout the United States and the world. The board's main role is to certify, and it's been doing that for 40 years, responsible and competent practice of cosmetic surgery. And we wish to promote the concept of equivalency, meaning that anyone performing involved cosmetic surgery should have equivalent training as our diplomates. With that in mind, I really appreciate the invite. I encourage you to join us at our next Academy meeting, and please look into our fellowships. You will not be disappointed. Thank you.
Thank you, Dr. Banky. And now we'd like to bring Dr. Amala Kamath on stage. She is the current president of the Cosmetic Dermatology Society of India, and we'd love to hear some words from you, Dr. Amala.
Thank you so much. I'm indeed honored to be here. The Cosmetic Dermatology Society of India has been around for 25 years. So it is indeed a silver jubilee year this year. Over the years, we've taught a lot of our members and delegates who attend our conferences on how to use various cosmetic procedures. We've taught them the peels and the toxins and the fillers and the threads, and we've even taught them how to use the lasers. And we're very excited to announce our conference this year in June, between the 10th and the 12th, where we intend to give a lot of more educational take-home messages as well. This year, we have a sister society section as well. And IMCAS is one of the societies that are going to be there in our sister society. We also have societies from Bangladesh and Nepal and Sri Lanka who will be participating. Our delegates are usually not only Indian, but from all over the world. So do try and attend the program. Thank you.
Thank you, Dr. Amala. And now back to North America. We're going to introduce Dr. Jennifer Sivak, who is the current president of the American Society of Ophthalmic, Plastic, and Reconstructive Surgery. Jen, thank you for joining us today.
Oh, thank you, Tanuj, for inviting me. On behalf of ASOPers, I'd like to welcome everyone to the Global Cosmetic Surgeon Aesthetic Masters class. ASOPers was formed in 1969, and over the last 50 years, we've had a wonderful opportunity to form many fellowship trainings, over 50 now. These are 2-year fellowships in oculofacial surgery, and they're really the jewel of our society. As an organization, ASOPers is privileged and proud to support this event with several of our members as faculty. It's an incredible venue for international collaboration, and it presents us a unique opportunity to learn from each other. And we look forward to the fellowship that today's meeting provides in future events like this one. Thank you. Thank you to all of you.
Thank you so much, Jen. And then finally, last but not least, we have a good old friend of mine, Paul Carniol, who is a facial plastic surgeon and also has some overlap into the ACS world. Paul, you're the recent past president of the AFPRS. We're so pleased to have you join us today.
Yes, thank you for the invitation and including us in the presentations. I want to thank Tanuja and Debraj for organizing and running this excellent meeting. Many great presentations. The facial plastic and reconstructive surgery has many aspects, and the cosmetic aspect is certainly very important to all of us. As you all know, I'm very interested in new technology and techniques, and I can't wait to see the relevant presentations. We have upcoming meetings to which I invite all of you. We have a Masters in Rhinoplasty and Facial Rejuvenation meeting in May, which will be held in Miami. We also have our annual meeting, which will be held in October at National Harbor, just outside Washington, D.C. You can fly into Washington, be right there. It's right close to the airport. Physicians from several specialties can join the Facial Plastic Surgery Academy, and that includes international members as well. If you're considering this, please contact our office. Tricia Dare is in charge of this, and that's located in Alexandria, Virginia. Her number is 703-299-9291. And once again, thank you for including us. Thank you for organizing this excellent meeting, and we're so looking forward to it.
Thank you, Paul. Once again, it's just such a pleasure for us to see all of these heads of the most important organizations in cosmetic surgery of the face up here all on stage together. What a moment. Thank you all for joining us and for having your organization support this meeting by raising awareness. We are looking forward to a great set of lectures here. And now I'd like to have Dr. Andrea Tooley take the stage here. She's going to introduce the first session, which is Eyes and Upper Face. And for those of you who don't know Dr. Tooley, she is faculty at the Mayo Clinic and is one of the rising stars and ASOPers. And we're so grateful that you could join us today, Andrea. I know you have a lot going on with your family in town and a young child, but you're never one to say no to academics. So thank you.
Thank you so much, Tanuj. Anything for you. It is an honor to be here. I have my 6-month-old in the background, so apologies for any coos that you hear in the background, but it is an honor to be here. I have my co-moderator here with me as well. You already introduced Dr. Jorge Corona, who's an oculoplastic surgeon in Dallas. And so we will be moderating this eyelid session. I'll introduce our first speaker to you here. We have Dr. Milind Naik, who's an oculoplastic surgeon practicing at the prestigious LV Prasad Institute in Hyderabad, India. He trained at UCLA with Bob Goldberg, so he has outstanding training. He is an active member and past vice president of the Asia Pacific Society of Ophthalmic Plastic and Reconstructive Surgery. He's also a leader with the Ophthalmic Plastic Association of India. So welcome, Dr. Naik.
Thank you. Hello, everyone. Good morning, good afternoon, and good evening. At the outset, I'd like to thank Tanuj, Debraj, and the entire Global Cosmetic Surgery team for this wonderful program. And I'm honored to be here as well as to be the opening batsman. So I'll try to cover as many pearls as I can in 5 minutes. So first of all, I would like to mention that lower blepharoplasty as compared to the upper is much more complex in terms of not only the anatomy, the hills and valleys, the surgical options that we have, the simultaneous Canthal procedures that are required, and even to keep in mind the negative vector of the lower eyelid. One of the pearls for a novice is to ignore the prominent orbicularis roll, which might look like a bag, and that actually needs botulinum toxin rather than a surgery. Another red flag is if you have a patient who reports recent increase in fat bags, or the person is not really within the age category, or if the fat bags have also been accompanied by other eyelid signs, you might want to check out their old photos because this could just be thyroid eye disease. It's important to know this not only from the systemic standpoint, but also their response to your blepharoplasty surgery could be a little exaggerated. I know that all roads lead to Rome, but all the bags need not lead to blephs. So if you have a very tiny bag, it can be easily camouflaged by a filler, as you can see in this particular patient. So if you have the height of the fat bag, which is actually less than or equal to the depth of the tear trough down below, and this is just by eyeballing, you could probably just fill that and get rid of the contour changes without having to perform a blepharoplasty. And these are the examples, and this would be my fourth tip to try and avoid bleph for patients who have very mild eyelid bags. However, if the height of the fat bag is excessive in comparison to the groove below, then you might have to do a bleph and take out the fat, as is seen in these examples with transconjunctival blepharoplasty. About markings, the best way is always to do it when the patient is sitting and awake. You can just gently have pressure placed on the globe so that the fat pad becomes prominent and you complete your markings during this step. Or else, if the patient is lying down or is already anesthetized, you might just gently press on the globe to make the fat bag more prominent. Talking about anesthesia, it is very important, especially under local anesthesia, to notice the contour changes. And for that reason, injecting the smallest amount of local anesthetic, and sometimes if required, to assist that on the conjunctival side to have good anesthesia is important so that you can appreciate contour changes during surgery. Some of the tips during surgery, if you see blood vessels within the fat bag, it's always good to first target that vessel at the base and then begin to remove the fat. And rather than using clamps, I prefer to have my assistant hold a Q-tip just underneath the fat so that it can protect the other soft tissue. And I don't really have to have a metal clamp which could touch other tissues and transmit the cautery. Here is a tip for those who haven't ever seen an inferior oblique muscle. This is the right eye being operated surgeon's view. Inferomedially, you can see that it's a reddish pink glistening tissue just within the orbital rim. If you see something like that, stay away from it. It's very important to keep checking the contours throughout the surgery. Here you can see the left side tear trough is unmasked very well as compared to the other side. This helps you understand how much fat has to be removed and made symmetrical on either side. I always end the surgery by injecting some amount of 5-fluorouracil or steroids to just begin the anti-inflammatory action right on table. And another tip that I've learned from Dr. Naresh Joshi, and I'm practicing it for years, is to include the anti-inflammatory right in your block. Last tip is about the skin excision. It's important to know that the upper eyelid is more forgiving with skin excision as compared to the lower, and therefore lower eyelid skin excision has to be very conservative. And if you have to do it, it is only to improve the static lines which might worsen after your blepharoplasty. Just a couple of examples here of patients with pre and post lower eyelid conjunctival blepharoplasty. And this is a case with a combination therapy of a bleph followed by a filler. So here were my 10 pearls in 5 minutes. Thank you so much. And I look forward to hearing the other speakers.
Dr. Naik, those were fantastic pearls. I learned a lot about lower blepharoplasty. I love how you touched on using 5FU at the time of lower bleph. That's a new tip for me. So those were outstanding tips. Thank you so much. I'm going to move on to our next speaker unless anyone has anything else to add. All right, great. Well, our next speaker is Dr. Kasturi Bhattacharjee. She is an oculoplastic surgeon who is currently the academic and clinical director of Sri Sankadeva Nethralaya in Bhota, India. She is very involved in research endeavors. She's published over 70 publications in national and international peer-reviewed journals. She's a leader in the field, has held multiple positions within Ophthalmic Plastics Association of India. So welcome, Dr. Bhattacharjee.
Hi, good evening. This is Dr. Kasturi Bhattacharjee. I'm from Sri Sankadeva Nethralaya, Guwahati. At the outset, I would like to thank Dr. Tanuj Lakra and Dr. Devraj Shom for giving me an opportunity to be in this prestigious meeting. And I'll be speaking on pearls on under-eye dermal fillers. No financial interest. So my indication for under-eye fillers are basically first the correction of the teardrop defect and secondly the concealing of the under-eye bags. So this teardrop defect is basically defined as an oblique fissure-like conjunctive deformity, which arises from the teardrop ligament that separates the palpebral and orbital portions of the orbicularis oculi muscle. And you look here, this is a teardrop ligament, which is basically an osteochondrous ligament. So we should know the difference between a correct teardrop and incorrect teardrop. The correct, as usual, all of us know, it is basically a separation of the palpebral part of the orbicularis from the orbital part of the orbicularis, but many times we have an incorrect teardrop, which is basically the separation of the orbital part of the orbicularis from the levator elegans. And I really like this classification by Sadik et al., who classifies this defect so well as hill, valley, hill, valley. The hill, valley type 4 and the type 5 being a mix. So how do we treat this area? Basically, it can be done by the injection technique, there's a needle technique, or it can be done with a cannula. The most important part is that you need to inject bolus of these dermal fillers along the inferior orbital rim. As you can see here, this is, you can see a very small elicate of this dermal filler has been injected along the inferior orbital rim. So as you see here that as I have been injecting along the inferior orbital rim and starting from the medial to the lateral end, as you can see here, and then once you see that once this part is being over, when this side is over, you can see a very beautiful correction of the teardrop, and also you can see the concealing of the under-eye bag. So this side has been corrected, and then I go to the other side, the same procedure where you inject a microbolus dose of the dermal filler along the inferior orbital margin, and also it's very essential that you aspirate before you inject the procedure. But what I feel then nowadays, I usually prefer more using a cannula, like in a patient like this, where you have a very prominent teardrop and also you have also the eye bags. Such situation, I usually prefer using the cannula, where first I mount the inferior orbital rim, and I approximately 0.5 centimeter below that I mount the second line, and I try to stay in this plane of the inferior orbital rim, where I make an entry with a 25 gauge cannula, and you can see I usually inject it along the inferior orbital rim. And so I follow this stream and slowly a very small bolus dose of the filler, the dermal filler is being injected. This is what you can see, as you can see that both of the sides are being done at the same sitting. And you can see that the cannula is being used, that is a 25 gauge cannula that is being used to inject along the teardrop defect and also the inferior orbital rim. And you can see the beautiful result. This is the same lady, 2 days. This is 2 days following the procedure. That is the pre-injection, then other the post-injection, giving a very good correction of the teardrop defect and also a good correction of the concealing of the under eye bag. You can see these are the patient done with a dermal filler, which gives not only correction, it corrects the teardrop, but also it conceals the pad, the lower lid eye bags. It can be seen very well before and after the procedure. And not only this, you can see a very good correction of the negative vector to a positive vector, which needs a very good effacement of the inferior orbital rim. There's a lid cheek junction. And the results are just immediate, like as you can see here, you can see this is the site of the cannula just at the time of the injection. And the results are so much a different, beautiful results you just get after the procedure. But what I want to say that the teardrop, here I quote Professor Mauricio, who says that teardrops are not as friendly as dogs. They can be tricky like the cats and can be dangerous as a lion because there are this is a high risk zone and there can be complication in the form of swelling, ecchymosis, skin discoloration, and also the vascular complication. So the needle injection can sometimes lead to lumps and a bump, so you need to highlight the situation. And sometimes you can have small nodules here and there. The tindon effect can also occur, but this I usually have seen with a needle. Now I use the cannula. I have not come across such situation. And also what we basically fear is a vascular complication where there can be accidental intravascular indication, intravascular injection, and this can be either a local effect or can be also a distant effect. So in such situation, if we have any complication, the best is we need to inject hyaluronidase, and if it is a small localized effect, we can approximately inject 10 to 20 units or up to maximum 40 units. But if there's a vascular complication, we need to flood the area with the hyaluronidase. Thank you very much for your kind attention, and thank you, Dr. Tanuj and Dr. Debraj, for having me in this meeting. Thank you.
Thank you so much, Dr. Bhattacharjee. That was an outstanding presentation, beautiful results. I really love the technique you showed with the cannula, putting it right between those 2 lines on the infraorbital rim. Such beautiful results. I will move on to our next speaker now. It's my pleasure to introduce Dr. Naresh Joshi. And Dr. Joshi is a world-renowned oculoplastic surgeon who practices at Cromwell Hospital in Chelsea and Westminster. He in England. He's known for his thoughtful approach to periocular aesthetic surgical rejuvenation and is also a founding member of the British Ophthalmic Plastic Surgical Society. So welcome, Dr. Joshi.
This is a 5-minute overview of upper blepharoplasty. A full version of the lecture will be available through a link I will show you later. I thought the best thing is to show you a routine upper blepharoplasty and talk through it. So the inferior border is usually at the skin crease, extending from the puncta to the crow's feet, radiating superiorly. The superior border is determined by pinch technique, with the patient sitting up giving the best aesthetic points, and the patient lying down and pinching, allowing for the best functional marking, to ensure that you don't take too much skin and the patient is still able to close their eye. Once this is determined, this exact amount of skin is resected. Now it is possible to use either a blade, which is standard, or a monopolar system. The monopolar system allows for better hemostasis, but takes a little longer to heal and perhaps scars a little worse. If you're undertaking this technique, do it with wet field resection. With a blade, it's usually a dry field. It heals better, bleeds a little bit more. If you use tumescent hydrodissection technique under the subcutaneous plane, about 3 mils, it is easy to remove the skin completely from the orbicularis without damaging or resecting any of the orbicularis. The amount of orbicularis we will resect will be determined later on. So once The skin is resected completely, leaving the orbicularis intact. We can determine the amount of orbicularis that we will remove. The complete lateral orbicularis beyond the lateral canthus, as this is a brow depressor, which is what I'm removing now, and this is where we inject botulinum toxin to elevate the brow. And also we determine, in this case, about a third to a half of the superior orbicularis. The amount of orbicularis that you remove determines the volume that you leave behind. When you remove orbicularis, ensure that the septum is completely intact. Now, usually at this stage, we will need to determine whether we need to change the volume further of the upper eyelid. Usually the medial third of the upper eyelid requires volume manipulation. The lateral third, lacrimal gland repositioning. So if you want to manipulate the volume, either resect or realign, you will need to free up both the medial pole of the preapicneural fat pad and the medial fat pad itself. Once you've done this, you can either realign for A deformities, or in many cases, simply resect this area. And this is done with complete hemostasis, removing both the medial pole and the medial fat pad, as it's shown here. Now, this is only necessary in certain patients, and as I say, sometimes you will leave the volume and even enhance it. Here I'm performing septal thermoplasty to create a base for suturing. Now, I usually use a technique of suturing with deep 6-cervical rapide sutures, holding it onto the septum high up in the lateral third to elevate the lid show. At this stage, and now I'm often undertaking complete closure of upper eyelid surgery with deep 6-cervical sutures alone, without using any skin sutures. And instead, now I often use glue, as in dermabond. But it is possible, of course, to continue to use proline sutures, either in an interrupted form, as in this case, or a subcuticular form. If you use just deep sutures and a dermabond, you'll be able to avoid the patient coming back at a certain time for suture removal. So that is the preferred technique. I hope that gives you an overview of upper blepharoplasty. There are, of course, many ways of doing this. This is simply one surgeon's technique. If you wish to watch the whole video, which is 45 minutes, please take a screen grab of the link. I'd like to thank all those concerned, especially Tanuj and Debraj for organizing this, but I'm sure there are many, many more behind the scenes working equally hard. Thank you very much, and goodbye.
Dr. Joshi, thank you so much for such an elegant video of an upper blepharoplasty. I think we all took a lot of tips away from that. I love that focal lateral orbicularis myectomy to get a subtle elevation of the brow, but so many beautiful techniques there. So thank you for your pearls. I'll introduce our next speaker, who is Dr. Ho Seok Sa. He's an oculoplastic surgeon practicing in Seoul, Korea at the Asan Medical Center. He's involved with the Korean Society of Ophthalmic Plastic and Reconstructive Surgery, has numerous peer-reviewed publications and book chapters. So welcome, Dr. Sa.
Ladies and gentlemen, I'm Ho-seok Sa from Asan Medical Center, Seoul, South Korea. It is my real pleasure to talk about Asian blepharoplasty, specifically for East Asians. These Korean actresses have beautiful eyes with double eyelids, but these people also have attractive eyes, even without double eyelids. From the perspective of East Asian beauty, beautiful eyes have large palpebral fissures in width and height, regardless of having eyelid creases or not. But in most cases with a single eyelid, the upper eyelid margin is covered by the upper eyelid skin, and after double eyelid surgery, the upper eyelid skin is pulled upward and the patient will have a larger, more rounded eye appearance. That is the goal of Asian blepharoplasty. Among procedures of Asian blepharoplasty, I'm going to focus on suture, double eyelid surgery, and medial epicanthoplasty. There are various techniques of suture, double eyelid surgery. My preferred method is a single continuous suture method using a 7/0 nylon suture. The height of the lid crease is determined by patient's preference and characteristics, but typically 8 to 10 millimeters. After local injection, a step incision is made at 3 points. A 7/0 nylon suture is passed from the step incision to the conjunctiva just above the upper margin of tarsus and then back to the skin. Thereafter, the suture is passed to the next step incision point to repeat the full thickness suture. Passing to the next. So 3 loops of full thickness suture at the upper margin of tarsus are made from the lateral to medial portion of eyelid. At the medial end, suture passes through the subcutaneous tissue to the lateral end. The suture knot is made and buried within the step incision. This young lady underwent a single continuous suture method, and postoperatively, she has a thin, natural double eyelid crease, which is favored by most East Asians. Medial epicanthal fold can give the illusion of a wider intercanthal distance and blepharoptosis. Furthermore, if prominent epicanthal folds are not addressed during the double eyelid surgery, it may cause the unnatural appearance with the semilunar fold. Therefore, it is necessary to consider the concurrent medial epicanthaloplasty. There are various techniques of medial epicanthaloplasty according to the type of skin flap. Personally, I prefer a modified skin redraping technique in combination with incisional double eyelid surgery. The new medial canthus and the original canthus are marked. The blepharoplasty incision line is drawn and connected to the original canthus. After local injection, a skin incision is made between the new and original canthus, and the dense fibromuscular tissue is removed to soften the medial epicanthal fold. The upper eyelid is resected accordingly. After the skin is redraped, the dog ear on the lower lid is corrected. The dense fibrotic tissue and orbicularis muscle that consist of the medial epicanthal fold can be additionally removed. You can put the medial canthal forming suture with absorbable material such as 6/0 Vicryl if you want. Then the interrupted skin closure is performed using 7/0 nylon. You can see the strong medial epicanthal fold is well corrected. These are pre and post-operative photos. This patient didn't want to have a visible crease, so I made a skin incision at 3 millimeters from the lid margin. In conclusion, the goal of Asian blepharoplasty is to create a double eyelid crease retaining Asian ethnicities and not to make westernized eyelids. Choosing appropriate technique is important, and medial epicanthaloplasty should be combined in patients with a prominent epicanthal fold. Thank you for your attention.
Thank you so much, Dr. Sa. Those were fantastic tips for challenging Asian blepharoplasty and medial epicanthaloplasty. So thank you for sharing those pearls. It's my honor to introduce our next speaker, our leader, my friend, Dr. Tanuj Nakra. Dr. Nakra is an oculoplastic surgeon in Austin, Texas. He is a fellowship director for the American Academy of Cosmetic Surgery and is a fellowship preceptor for the American Society of Ophthalmic Plastic and Reconstructive Surgery. He's also started his own skincare line called Avaya. He is one of our co-founders of Global Cosmetic Surgery. So welcome, Dr. Nakra.
Thank you, Andrea. So I will attempt to give you 10 tricks to enhance brow lifts in 5 minutes. So, I think a brow lift is one of the most powerful ways to change the periorbital aesthetic. It's truly an upper facelift. And some of these tips and tricks that I've developed over the years are tricks that I've learned from others and we've developed along the way. So we'll start with a custom vector lift. So when we're performing a brow lift, it's very important to understand that there's asymmetries related to bone and soft tissue, and we can modify some, not all of these, by adjusting our vectors, not only locations, but how much force is utilized during the lifting process. In the preoperative area, I will sit and take time to mark the patients out, and you choose locations that achieve the brow shape that we're trying to obtain with the procedure. 2 paracentral incisions and 2 temporal incisions are standard, but I will add and subtract incisions as needed to get the vectors to be just right. The second tip is zigzag incisions behind the hairline will allow the hair to grow in different directions afterwards and reduce the visibility of these scars. At about 6 weeks, this paracentral incision has almost disappeared. The temporal incision is usually an ellipse, as I've marked out here, and I'll spend time talking with the fellows about fixation points internally, as well as where's the facial nerve as we're designing these incisions. If the temporal incision is not directly over the temporalis fossa, no big deal. We'll manage that with bone fixation, as I'll discuss in a moment. It's very important to dissect under the astrogals or the intermediate fat pad, which is in the temporal region. Dissecting under the temporal fat pad, sorry about the audio overlay here, but dissecting under the temporal fat pad will allow for safe dissection under the facial nerve and also exposure of the medial third of the zygomatic arch in a safe way that allows us to be appropriately aggressive, but also safe with the facial nerve. It's important to have a full ligament release in a brow lift. Here's a demonstration of the release that's been performed in a standard lift. Lateral brow, medial third of the zygomatic arch, down to the malar ligaments and the superior masseteric attachments, and also to the lateral periorbital attachments, including orbital retaining ligament. This is a standard release, commonly done for a mid-face lift, but I'll utilize this in brow lifting. And after this release, my fifth suggestion to add to your practice is the Trepsat flap dissector. This is a fantastic instrument that I like to utilize techniques that are a combination of aggressive and safe at the same time. So this device right here is a modified scissor with these flat portions that allow for flaps to be dissected. In a brow and cheek lift, it could be introduced down into the malar region and spread fairly aggressively. This is perpendicular force to the direction of the facial nerve, so it's safe for the nerve branches, but then it really achieves a full release. So after releasing malar, lateral orbital attachments, we can now see that by lifting the skin edge and the superficial fascia, we can lift the entire face, including the jowls from the temples. That's powerful. Now, speaking about the glabellar medial region, it is important to release the supraorbital nerve. I utilize a closed scissor. This is a Messenbaum scissor where we actually release the periosteum from the nerve and strip the attachment so that we have a complete elevation of the superior orbital structures. And then we can also approach the glabellar muscles in a similar way to expose the corrugator and procerus muscle. Each patient has their own situation, and we need to identify what each patient needs and modify not only individual anatomy, but also asymmetries as well. We can use a nerve hook to separate out these supraorbital and supratrochlear nerves from the corrugator muscles. And in some cases, we'll make the choice to actually remove the mid portion of the belly using a pediatric Takahashi to achieve a more substantial permanent weakness in this region to raise the head of the brow. I like to use bone tunnel fixation because it allows for infinite variation and customization as needed. We use a high-speed drill angled at 30 degrees in the outer table of the bone. We have 1 centimeter until you get to the dura. So you can free drill here at 30-degree angles. This is being demonstrated in the paracentral incisions where we have that curved incision, as you can see. Once we've got this drill in place, this drill hole in place, we can pass a monofilament suture with a taper needle. and we can grasp the periosteum and galea and frontalis from the undersurface and place the vectors exactly where we need them. The tension of these sutures can be adjusted as needed to enhance symmetry. Temporally, as I'm demonstrating here with a coronal approach, this is how I fixate all the temporal incisions. This is a mattress suture that distributes the tension out to avoid injuring follicles. If you cannot fixate to the temporalis fascia because the location isn't working for the vector required, you can simply place a bone tunnel adjacent to the temporal fossa. Finally, this type of brow lift where we're really doing an upper facelift, releasing nerves, releasing ligaments, patients can have postoperative pain. I find it very useful to follow the advice of orthopedic surgeons and gynecologists who use Cymbalta perioperatively, along with preoperative Tylenol and gabapentin. Also, it's important to recognize that a lot of patients have caffeine withdrawal after surgery, and especially with brow lifting with the supraorbital nerve, that can be particularly painful. So all my patients are offered Coke and Mountain Dew after surgery, which can be very helpful for some of them. This pain control regimen does reduce narcotic use, which is our responsibility as surgeons in this day and age. Thank you very much. I'd be thrilled to engage with you offline. This is my social media handle, and you can reach me there. Thanks.
Thank you so much, Tanuj. Really fantastic talk. So many great tips on brow lifts. I love that TripSat flap dissector. I'm definitely going to order that. I think we'll be able to open it up for some questions for all of our speakers coming up soon. And I will have my co-moderator join me, Dr. Corona. So we're excited to take any of your questions and discuss with these exceptional panelists.
So I have a question for Naresh. Can you hear me?
Yes.
Okay, great. Hey, Naresh, great to see you always. And my question is, I think as time goes on, I mean, we're removing less and less of the orbicularis. What are your findings on patients who had the orbicularis removed many years ago if you follow them years later? Are you removing more or less orbicularis? I do like the technique of removing it more on the temporal side to have a little bit of release on the temporal brow. So if you can give us a little bit of feedback on how much orbicularis are removing now compared to in the past.
I'd say it hasn't changed considerably. I've been doing it for about 26 years. I suppose I don't see all my patients for that long, but the ones who come back for Botox, for example, I don't see a great deal of difference. I think there is inevitably change in volume of the upper eyelid due to fat reduction. I don't think the orbicularis resection of a third makes that much of a contribution, but I may be wrong. Certainly, we've moved away from removing fat from the upper eyelid, except for those cases in whom there is an obvious bulge out of sync with the rest of the upper eyelid. So the medial third is the only place that I will occasionally remove fat, but otherwise not. If I think there is volume deficit, one of the things that I will do is to score, after I've taken the orbicularis out, I will score the septum to allow for fat herniation. You see what I mean? I'll weaken the septum without cutting it. So just thin it to allow for fat herniation. So if I think there's a very hollow eyelid globally, that's what I might do. But I don't know others' experience, but my own experience is that orbicularis resection of the amount that hasn't made a big difference in volume.
Thank you.
I will say, Naresh, that when I was in training, I watched you present some of these techniques, and for the last 13 years, I have been resecting orbicularis the way you taught me. And you're right; it doesn't change the orbital volume that much. It just changed the brow position in a very positive way. You can. I'll tell our fellows that we can do an asymmetric orbicularis surgery to adjust brow position to a mild degree. So thank you for your teaching points. They've certainly been useful here. 1,000 patients in Austin have your signature internally as well.
Makes me feel very old, of course.
come from Australia, so we have a lot of dermatocrisis or patient who's excess skin, excess epiglottis. So those kind of patients don't take epiglottis up, they have much higher recurrence. So they're excess both skin and epiglottis. I think depend where you're from. You know, where there's excess skin and epiglottis, you have to take some epiglottis, I think. It helps us the brow as well. I do a lot of brow pexy, but I'm not afraid to resect the epiglottis, especially laterally.
Milind, you had a couple of questions for Tanuj as well as for Hoseok.
Yes, a question for Dr. Sa. I was asking whether the non-incisional technique, is there a way to ensure that the suture doesn't get exposed on the conjunctival side? And how does has he seen any problems with that?
Yeah, thank you for the good questions. But in my humble experience, I have never experienced the problems related to the exposed suture to the conjunctiva side. So but sometimes some plastic surgeon in Korea, they prefer get through the tarsus instead of the upper margin of the upper border of the tarsus. But in case of that technique, which penetrate the tarsus itself, I think there is a good chance to make a problem, such as the irritating cornea or something like that. So sometimes I need to remove the suture, and in that case, usually the lid crease would disappear, but it's not the big issue because it's very easy to reperform the non-incisional technique to make a lid crease again. Thank you.
Thank you. Well, my next question was for Tanuj. Tanuj, for the bone drilling, for the bone fixation, do you use any kind of stabilizer which kind of guides you exactly at what angle you should be drilling, or is it approximate?
You know, it is a free drilling situation. There are devices that allow you to have a template to get just the perfect angle onto the bone. They're a little cumbersome. They're hard to fit in the wound. We don't really use them. You know, I think the learning curve does exist for bone tunnels, but you know, there's a whole centimeter between you and the dura. Even if you go through, it's not the end of the world as long as you're not through the dura. And that has never happened with our cosmetic cases. So I think that it's a technique that is fairly straightforward, quite safe. And the reason why I like it so much is because it's infinitely flexible and customizable depending on the situation.
Thank you.
Should we just move on to the next section and then come back to questions at the end?
Any additional questions? We might have room for one more because we are happily on time. Andrea, anything else that you'd like to add or inquire from your panel?
I've been checking the chat to make sure I'm not missing any questions, but I think we are up to date. These were all really fantastic talks. I appreciate being able to join you all. Thank you so much.
Can I ask one last question?
Yeah, sure.
Tanuj, if you can just give us a really quick point of when you do the temporal dissection to avoid the injury on the facial nerve and to identify the proper plane, because I think there are simple ways of doing that to avoid really a serious complication. Give us your 1 minute pointer on that.
Yes. So I think that's a critical part of the dissection to really get beautiful results. And the safe plane is below the intermediate fat pad. And we also will avoid getting into the middle third of the zygomatic arch. All the dissection is the medial third, which keeps us in the safe zone. And then finally, once we have that dissection down onto the zygomatic arch, the Trepsat spreader really allows for a good separation there. And then a final trick is to make sure your dissection goes superiorly as well. I have a full release of the tissues from frontal parietal bone laterally, along with a full release of the conjoined tendon. Once you have all of that released, you get mobility.
Thank you.
Safely. Yeah. Well, thank you to Andrea and Jorge and the entire session 1 group. I would say that is a powerful hour of periocular aesthetics. So thank you very much. We are now going to transition into the second session, which is going to be a high yield tour through aesthetic lip enhancement, both surgical and non-surgical. And let's bring Dr. Tuan Pham back on stage here. He's a facial plastic surgeon in Perth in Western Australia. Thank you, Dr. Pham. Take it from here.
Thank you, Tanush. Thank you, everyone, for inviting me. It's a pleasure, this session. So I'm going to share my session with Dr. Atang Setentinga, who is an oculoplastic surgeon working in Baskan University plus Ankara Hospital in Turkey. He's a member of numerous associations, including the oculoplastic section of the Turkish Ophthalmology Society. So my first speaker is Dr. Ben Talay, one of our facial plastic surgeons from Bellevue Hill. He's a fantastic speaker and well-known, and he's an extension fellow who is serving over the years. Plus, he's a lot of focus and expertise on deep plane lip lifting and facial rejuvenation, and I think his talk will be very informative. And welcome, Ben.
Thank you. Thank you. All right, so let me time myself for this 5 minutes of lecturing. So I'll go through the pearls that I can share within 5 minutes, the most important things and the things that I find unarguable, that you can't really argue, because people do lip lifts so many different ways. And this conference, from what I've heard, everybody is so diplomatic and understanding, and I'll be the one not to be diplomatic. I'll just tell you what really doesn't work and shouldn't be done. So the number one pearl is make a proper incision. When people do limitations on the incision, doing smaller incisions or Italian lift incisions, it's like trying to lift one of these dumbbells with like two pinkies. You can't redistribute the weight. You're gonna, except for this guy, but you're gonna break your pinkies unless you have Chuck Norris's finger. So it's better to just get a regular grip and really lift everything easily. Now, when you look at the different incision types, you can see here that there are gull wing, double duck incisions that go inside the nose, around the nose. All these different things were done in order to get rid of or hide the scarring, rather than do the most important thing, which is just get rid of the tension. And the same error was made in facelifting. Rather than just fixing the facelift and releasing the gliding plane or the deep plane of the face, people would just find different ways to hide the incisions up in the hairline and alter the anatomy, and never works out well, and it can't be fixed. So the number one thing is, do not place an incision inside the nose. This will forever scar and skeletonize your patient, as you can see down over here, and you cannot fix that. So that is not arguable. And people come up to me after every lecture, are you sure? I find that I get good results. And I say, I know you find that you get good results, but if I were to stare at your results, I would vomit. And there's no nice way to say that. They just don't know any better. So I try to be harsh about it before they come and ask me those questions. So do not place incisions inside the nose. Stay at the junction. Do not put the lip inside the nose. And that's what happens. You skeletonize it and you put the lip inside the nose. So deep plane is the other pearl, is perform some kind of release. The release in the lip is the deep plane, and that's going between the SMAS and the orbicularis muscle. And it is clean, obvious anatomy, but most people don't know it. They're not aware of it because they're not familiar with the SMAS. If you're a deep plane surgeon, as soon as you go into the lip and you separate out those layers, you say, oh my God, there's a SMAS here that's just as thick as the midface, which means that there's a lot of volume contribution from it, and overall a lot of strength when you want to move it over. So at this point, I've done about 3,000, but I'm going to submit this paper in ASJ, which was 2,500 patient review, and really goes over all the different things to look at. Now, here's the other big pearl that I've learned, and I forgot, I mean, it's a well-known saying in surgery that it doesn't matter how genius you think you are, how great your surgery is, if you can't make it reproducible and understandable for other surgeons, it isn't anything. And the real kind of genius in this stuff becomes making it reproducible and easy. And that always stuck with me because I like to teach, and people taught me, so I feel like I have to teach others. And I came up with this whole Cupid thing. So I've made it reproducible now because I saw a lot of problems within my own design. And if you look at these lines, these are the relaxed skin tension lines of the lip. CPID, that's Cupid. There's an outer line as well, which helps you control the outer part of the lip. The really important part about looking at this is if you look at this diagonal line separates what we call the subfacial lip, which is over here, versus the subnasal lip. The subnasal lip is hanging from the nose like a lampshade, and it doesn't age much over time. The subfacial lip is hanging from the face, and it hangs down over time. And this has a lot of implications because the lateral lip over here, lateral to the diagonal, doesn't lift with fillers. And if you've ever tried to fill that area, you realize you struggle. It doesn't evert. It also doesn't lift with surgery. The lip lift only lifts between the diagonal lines. So this is very important. Everyone's lip, when you do a lip lift from a subnasal incision, tends to lift just in the middle, not in the sides. So the other pearl is you have to design it in a way where you're going to balance for this, whatever the patient's anatomy is. So those are the Cupid lines. You really have to figure out the excision height on each patient based upon their tooth show, based upon the balance for the face. And this is the other pearl. There is no number to give to the lip. Patients come in, how long is it going to be? How much do I exercise? How much are we taking out? I'm like, why do you care how much we're taking out? What if I say 5, does it make a difference to you? 6, does it make a difference to you? 25 kilodaltons, does it make it? They don't understand. They just want to know a number because they read online that there's numbers. Surgeons are the same way. They want a number. There is no number that needs to remain for a lip to look good. It could be 16 millimeters. It could be 13 millimeters. But there goes my timer. So I'll be done soon. So it is helpful to have excision heights to understand how much tooth show you're going to get. This is the Cupid lift, this is how you design the residual heights. You want to have an even slope going down from C to P to I to D. So P, I, and D have a 2 millimeter slope between them. And then the outer line should be also about the same, 16 millimeters. But that's how you design it in order to keep the lip balanced. And the reason behind this is the Pythagorean theorem. You see that under the nose, you get a pure vertical lift. When you go out more and more, it's a diagonal lift, which makes the vertical component of your lift less. Okay, so that means that we have to really lift more on the side than the middle for most people. And then we find that the failures really come in these patients, or at least my old failures with the classic subnasal, is that if they had a wide nose, a narrow nose and a wide mouth, you see that this lateral to the diagonal is a longer distance. So this part on this patient didn't get lifted. So that's a failure on my part. This patient had a wider nose, wide mouth, same lip lift, but fully successful because the diagonal goes all the way out to here and she got lifted all the way across the lip. You get full exposure of the lip. So I figured out with these patients, you have to draw the diagonal line and anything lacking lateral to that needs a corner lift. Okay, so these are all the pearls and that's just a corner lift, just a corner lift. This is what I figured out. So this is my old lip lift. So this was a lip before I did it. This was my lip lift, the way I used to do it. This is revising the lip lift with my new design with the whole slope, the 2 millimeter slope. And you see how much more exposure you get on the same lip all the way to the ends now. And the lower lip has a better insertion point now, just like the canthus of the eye. So you can see that old lip lift, new lip lift, big difference. And these are the incision design examples, just so you get an idea of what goes into it. But it's really just drawing out that 15, 17, 19, that 2 millimeter slope. You can see, and you can change an M-shaped lip into a nice lip. You can change a weird bowing lip into a nice lip. You can do these revisions without thinking anymore because you never know what the surgeon before you did. So you can draw it out like this and you can do a revision without even thinking. So it takes the thought out of it, which is fantastic. This is the dissection plane, which you can find in the article. And then here you got the SMAS. You see how thick that SMAS is? SMAS is amazing. There's so much to talk about with SMAS, but I will not because I'm over time. And these are examples just so you see how they look. Balanced, even, and full exposure all the way across the lip without exaggerating any of the accents. This is a patient who looks mean and snarled in her lip. It's bowing if you look at that upper photo, and now it looks less exaggerated versus what most lip lifts do is exaggerate more. Down pointed angle. If you did a regular lip lift, that would exaggerate. On hers, you can see she looks happier. She looks more subtle overall. Same thing, same thing. Big fake lip, not as fake lip. Okay, can't get rid of all the fillers sometimes if they don't let you. Deflated, and you get the idea. All right, so thank you for letting me speak. And if you have questions about this, I will stick around and we can all chat.
That was fantastic, Ben.
Thank you.
So our next speaker is Dr. Chitra Anand, who's a cosmetic dermatologist who founded the Cosmoderm Mirror clinics in Bangalore, India. She's a pioneer in cosmetic dermatology and founded the International Academy of Aesthetic Medicine and with specialized training in cosmetic dermatology. So she's have more insight to our lips. So Chitra, thank you very much.
Thank you. Thank you so much. Thank you for the invitation. So let me just start. So, when I was asked to give this lecture, I figured that we'll just talk about the main practical aspects. But what I wanted to bring here were the 5 key points: knowing the anatomy and respecting the anatomy. Second was about the assessment of the patient at rest and in motion, because lips are extremely a motion sensitive area. So what looks great at rest may not look great at rest, at motion. So that's critical. Sorry, I think the slide is just running on its own. Give me a moment. Let me go back. There we go. Sorry, there we go. And I wanted to say it's not just a filler, because to choose the right filler is critical. To assess the lip, the surrounding area, and to think of combination techniques when somebody is doing this. These were the 5 main points. But just to talk a little bit about it, classify your lip procedure. What are you trying to do to that patient's lip? If it's thin, are you doing a correction? If it's normal, are you augmenting or enhancing that lip? And if it is an older lip, are you looking at rejuvenating? This will give us an idea of what you want to do, what product you want to use, and how much product you want to use in that particular lip. Otherwise, the lips don't get that natural effect. And there's nothing worse than humans quacking around, honestly. And when we look, understand what's happening with the aging effects on the lips, right? The volume loss, because we're talking about the loss of the lip projection, the drooping. So it's not just the frontal profile, but it's also the profiloplasty that we need to look at. So the lateral view and the frontal view is critical. The changes in dentition form a great part of what happens to the lip in terms of the inversion that takes place, atrophy of the bones, and muscular changes. When we think anatomy, it used to be 1:1, 1/3 to 2/3, but really it's what assesses to the rest of the face. If somebody has a very narrow face and you give them really circular full lips, it's not going to suit their personality. So you have to assess and do it according to that person's face. But always remember that when you do it and you look into the lateral profile, you want that line which goes from the nasal to the chin area right here. You want that projection of your lip, 3.5 and 2.2 millimeters. And that's critical. And if you don't get that change right there, that lip dynamism doesn't stay. The natural effect doesn't stay. And also keep an idea as to the height, upper lip and the lower lip, right? 15 to 20 versus 36 to 40 millimeters. Now, aging changes, just look at what happens. Younger lip, beautiful projection, and then there's an inversion, right? And the drooping of the corner, which Dr. Ben spoke so eloquently about, beautiful surgical results there. Few points to note, look at the shape, volume. Don't forget the filtrate. A lot of times people forget the filtrate and they just blow up the lips and it looks really odd. And also the balance between the two, upper and lower, the balance between the nose and the chin, the texture, definition, and movement. So when it's a younger lip, stay within the contours of the younger lip. Let's not try and overdo it, because it takes away from the youthfulness of the lips a lot of times. And these are the various techniques that there are where you go along the border, enhance the border to get that. And then now there's a lot of talk on the newer techniques, but they've been around for a long time, where you go in from the edge of the lips and then inject into the volume into this. This is for volumization. And also, again, don't forget the lateral view. That eversion that you get in the lateral sphere is fantastic. And with the older lips, keep an eye onto what's happening in the lateral deflation and also the marionette folds. I'm just going to show you a quick video. This is literally my last slide, because I wanted you to see this patient, right? Extremely thin. lips. But what am I doing? Before I inject the lip, I'm actually injecting the surrounding area. Because if I don't give her the support to the marionette fold right here, and I don't build out the volume in this area, she's never going to be able to lift the corners of the lip as naturally as possible. Otherwise, we're going to keep filling it, and then finally you're going to get a flip, and it's not going to be natural. So look at that. Just by putting filler into the marionette lines, folds, you can get that. And then go in and invert the lips. This leads to a more natural effect. Don't be stuck on that lip itself. Look at what's happening in the surrounding tissue. So in conclusion, respect the anatomy. I didn't spend too much time on it because everybody understands anatomy those days, but do respect it. Look at your injection. Superficial, deep, are you in the muzzle, out of the muzzle? So keep that in mind and assess at motion and at rest, because last thing you want is the lips filler to pop out when you've got them smiling. And at the end of the day, the best job is one where people say it looks great, but they don't know what was done. And so just keep that in mind when you're creating beautiful lips. Feel free to reach out to me on my Instagram profile. And thank you for inviting me today.
Well, thank you very much, Dr. Anand. That's fantastic again. And our last talk for the session is Dr. Michael Gold, who's practiced from Nashville, Tennessee in USA. And he's a pioneer in a lot of things in the pharmaceutical plus new technology, especially laser. So he's going to talk to us about the laser resurfacing of the lip area. Thank you, Michael.
Hi, everybody. This is Dr. Michael Gold, and it is my honor to be here to talk about perioral and lip laser modalities at the Global Cosmetic Surgery Aesthetic Masterclass, March 27th, 2022. As you know, I'm a dermatologist in Nashville, Tennessee. I'm also the editor-in-chief of Cosmetic Dermatology and Dermatologic Reviews. I do a lot of work for the laser business. I'm going to talk about some of the Cyton equipment in this talk. So we know that skin texture improvement and wrinkle removal are still in demand. Pre-pandemic, it was booming. And really post-pandemic, we have seen this really take off again. People are very interested in laser skin resurfacing. They were during the pandemic and when they had more downtime, but now that they're back in the workplace and trying to get back in the workplace, this is also being seen more and more. If you want a great review, this by Joel Cohen in 2015 in Journal of Drugs and Dermatology talks about erbium resurfacing, which is the focus of what I want to talk about today. Erbium resurfacing still is one of the best modalities that we have, whether it's full field laser resurfacing or ablative erbium resurfacing or with fractional components. Again, this article in June of 2021, also by Dr. Cohen, talked about the switch back to this full face erbium treatment for photoaging and how we can successfully use it in our patients. So again, combination therapy is very important. This is a treatment here with full field erbium and filler and botulinum toxin. You can see the remarkable results you're able to achieve. This is the Cyton Jewel system, one of the most reliable erbium systems that we have. We have a single spot handpiece, we have a zoom scanning handpiece, and then we have a fractional laser handpiece, which allows us great mobility with this kind of device. The erbium gives us this no detectable coagulation adjacent to the laser defect, which is very important for our patients. And again, this combination of erbium at 2940 ablation and dual pulse technology yields independent control of ablation and coagulation. So our history of resurfacing, there obviously are a lot of things out there. And most important thing that you need to take in mind is you need to consult with your patient on time. Because these are the kind of results we're looking for. This is 6 years post from Jason Posner. If a person says they have to get back to work today, we are doing a broadband light or an IPL. If they have 1 or or 2 days, we're doing what's called MOXIE, which is thulium laser and plus or minus broadband light. 3 to 5 days, we're doing halo with either BBL or with a fractional laser. And then if they can give us some time, we do full field laser. So this is the Contour TRL, this laser peel, which allows us to use variable depths for our patients. So somebody with photo damage, you can see the improvement here. But when we get into doing this around the mouth, you can see with several passes the marked improvement that you're able to achieve when you do perioral resurfacing with this Contour at 150 micron ablation. This is, again, Contour at 100 micron ablation. This is when you can get everything going with even a facelift involved. You see the results here. But again, you get really nice results that are reproducible when you do this with this kind of therapy. This is just a 150 micron, 50% overlap, 2 passes, and an additional pass over the deeper lines. Another patient here, here, and here. So profractional, this is actually using the erbium to deliver fractionated treatments. We can cover 5 to 22%. We can go as deep to as 1.5 millimeters. It's resurfacing perfected as an amazing toolkit for your skin. And again, we can use this in combination. Again, this is a broadband light and micro laser peel, but this is the kind of results that I want to show with the perioral resurfacing. Again, from Jason Posner, this is 2 months, 5 months, 1 year. Later, another patient's before in 4 months. This is 2 years post-op. Again, another patient, 1 year, 1 year, 1 year, 1 year, 3 years later, 1 year, 1 year, 6 years later, and again, 1 year, 2 years, and 6 years post-op. So you get this amazing resurfacing, amazing treatment with the erbium resurfacing. Thank you very much.
It was fantastic, Marco. So I hand it to my colleague to take some questions.
Thank you, Dr. Pham. That was an amazing introduction and a great session by 3 distinguished lecturers. So there are several questions. I'm going to address them each. The first question goes to Dr. Ben Tele. Do you get a dental assessment for all your patients, Dr. Tele? Does the way the teeth are determine how much skin you remove for the lip lift?
Yes. So I'm in most cases, I am the dental assessment. I have to look at the patient. I've been to so many dental lectures now that I have an understanding of not what needs to be done on each patient, but I have an understanding on who needs to be sent to specialists. So when we're looking at the lip lift, there's 2 contraindications. One contraindication in a lip lift is somebody who has a very severely exaggerated appearance. So severely anchored chelion and upturned central lip, things like that, where they're really exaggerated. It's hard not to exaggerate them more when you do a lip lift. So that's one contraindication. The other one is a dental skeletal imbalance, which means their teeth are too far forward, they're too much clockwise rotated, and they have difficulty closing the mouth. If anyone has difficulty closing the mouth, you'll see that they have mentalis hypercontracture and depressor anguli oris hypercontracture as they get angular depression over time. And this is because the upper lip has no depressor muscles. The upper lip is hanging over the teeth. And the lower lip, it's the job of the lower lip to come and meet the upper lip if the upper lip can't come down. So these people, if you ever do a lip lift on them, the strain on the mouth immediately starts to get worse and you start to age them faster. So that is a contraindication to it. So in those patients, I say, if they have a long upper lip and they have longer upper teeth, you have to go see your dental practitioner first. And your options in this world are 3 things. There's one, cosmetic dentistry, which usually is for lengthening, not for shortening, although it can do a little bit of shortening. There's orthognathic, which is really the big move of moving the bones around, and that makes incredible changes. And then orthodontic, which can also make pretty massive changes, even with small bits of impaction. So I do send for those 3 things, and I do tell them you cannot do the lip lift unless you do those 3 things. And the other consideration is, what if your patient has ugly teeth? If they have ugly, harsh, sharp teeth, and there's a whole lecture that dentists give on the character of teeth themselves, with square versus round versus triangular teeth. And if you expose somebody who has sharper teeth or teeth that doesn't match their face, the harmony goes away and you end up making them look worse because, yeah, you made the lip look prettier, but then you're exposing their ugly teeth. So I tell those patients, either I'm going to go, I don't tell them they're ugly, but I say either I'm going to go more conservative on your lip lift and not show as much at rest to make you look prettier in general, or I want you to go see this cosmetic dentist because the shape of your teeth doesn't match the rest of your face. And if you go make them softer appearing or more balanced, then I'll do a lip lift to the maximum and show your beautiful teeth.
And hide the beast, yeah, okay.
Exactly.
Okay, and there's another question about the corners of the lip. How much do you resect? You're gonna love the how much yes question. Okay.
This fell into my journey for teaching people and trying to figure out how do you reproduce this. And the manuscript that I've written for the ASJ explains it exactly how to do it. But you will, if you mark out for the Cupid lip, let's say 12 millimeters on the P line, 14 millimeters on the intermediate, and 16 millimeters on the diagonal, you've now created an even slope, and you want to continue that even slope as it goes lateral. And there's two ways to do that. So one is you draw your inferior line along the along the vermilion border. And then what you do is you pull up on your diagonal line, and now you just draw a straight line to the end of it. That's it. It's a straight line continuing from the 12, 14, 16. And then if you draw another line lateral, it should also measure 16. So that's the outer line. And I had that on the slides, but didn't get to go through it. But that's how you do it. And there's two types of corner lifts. There's a type 1 and a type 2. And this will, there's 958 or something articles in the literature about corner lifting, and they are all confusing and misleading. They don't really address why the corner needs to be lifted because they didn't understand the anatomy of the lip. Realistically, all you need to know is two things. There's a lip lift where you end it at the vermilion, a corner lift where you end at the vermilion and you just want to expose the vermilion that's hidden, versus you want to change the insertion point of the corner of the lip, kind of like doing a canthoplasty. And in this case, you make an inflection that goes past the chelion, just like an upper blepharoplasty, which doesn't cross the canthus, doesn't cross the commissure, and goes right back up, and you follow the natural contour of the lip, and that's where you finish and draw your straight line to. Anything that goes past, like a type 2, it ends up changing the insertion point of the lower lip, like a canthoplasty.
Okay, thanks for the answer. So for Dr. Chitra, am I pronouncing it correctly?
It's Chaitra.
Chaitra, I'm sorry about that. Okay, Chaitra. And as we age, the lip length increases. So should we go for fillers in this population or go for the lip lifting majority of the times? Well, what's your answer?
Well, I think Dr. Ben was talking about it for the surgical aspect. I only do non-surgical. So on non-surgical, I can comment. It really does depend on the balance between the upper lip and the lower lip and its relation to the subnasal and the chin point. And depending on that. Now, let's say someone's lip has lengthened quite extensively. It comes down to a ratio of 1:1 from the upper lip and the lower lip with a deep eversion, then this would be more of a surgical job. But if there is lip lengthening, we've seen effacement in the phyllal area, but the tissue lag is not so much on the lateral side of the lips, then a filler in these areas will help. Dr. Ben, do you want to comment on the surgical aspect?
Yeah, so are you talking about for the vermilion or the corner?
The lip lengthening. If the lip lengthens, do you want to fill it or do you want to do a surgery? When do you want to do surgery?
Yeah, so I look at it, first I look at someone with their mouth closed. And if their mouth is closed, I look at just the soft tissue balance of the face. And it's guided by the golden ratios. It's guided by that, but those are not strict ratios. When you look at, that's for when you're learning. So typically I look at somebody and I think, is their upper lip elongating their face? That's number one. Then I say to myself, also for the soft tissue part of it, is the vermilion hidden, or is the vermilion bowing, or is the vermilion buried on the sides? And in those cases, I say, I do want to lift this person. Then I open their mouth and I see, okay, can I lift them? So if they have 4 millimeters of incisive display, I'm not going to lift that person. Or if it's 3 millimeters, maybe I can do a 4 millimeter lip lift and I get no change. So I really have to just negotiate with myself. I want to when their mouth is closed. When their mouth is open, can I? and I look at it like that. As far as the vermilion part of it goes as well, you can do other things to get more vermilion show. You can do VY advancements. You can do injectable fillers. You can do SMAS grafting, and you can do fat grafting. Fat grafting is the least predictable of all these things, and everybody does it. And it's the least predictable because fat doesn't have a place in the lip. Filler is actually more natural. If you open someone's lip and you look at their lamina propria, the lamina propria is just like the SMAS. It's a cushy hydrated layer. So filler in there to the eye looks more natural than fat does. Fat's yellow and globular. It does not belong in the upper lip. I still use it from time to time in certain ways, but it does not belong there. Filler actually belongs more. It's a more natural thing.
Yeah, I agree with you on that about fillers looking more natural, because you can't, like you said, you can't predict the outcome. And sometimes it can look underdone, and it can look asymmetrical too.
Great, thanks. I think Dr. Gold is on the flight. There's one question for him. Dr. Chaitrike, could you please answer? And pretty quick, because we're running out of time, apparently. So the question is, when you have Smoker's lines, do you prefer fillers or perioral resurfacing? And when do you prefer which?
Got it. It really depends on the tissue and its hydration potential at that moment and the strength it has. So what I do is, in the eyes, you do a snap test. I do something similar on the lip area. If the skin bounces back really quick, there's good elasticity and collagen, and hydration is an element, then fillers will help, especially if they're under 40. But if they're over 45 and I see that the lines are rather deep set and they're running not just there, but into the vermilion, and there's a cut on the edge, then I prefer that we do a resurfacing.
Okay, well, great answer.
And to add in something too, because
pretty quick, please. Yeah.
Yeah, there's a question in the chat about the type of resurfacing versus on the lip for chemical peel versus laser.
Right.
For chemical peel is very difficult on the upper lip to get a big change unless you're an expert. Laser is very easy because it's reproducible, it's controllable. For the eye, chemical peel, I think, is better because you can get a bigger change without causing prolonged hyperemia. For the lip, I like to stick to lasers because of the control of depth. It's a little bit easier unless you're very seasoned and you do a lot of chemical peels.
Yeah, thank you so much for the answers. And, I've learned so much, and that's been a great session. Dr. Pham, any last words you want to close up?
I think that's fantastic. Thanks all, and to the next session.
All right.
All right. Well, thank you, Dr. Pham. Thank you, Dr. Chetnakaya, Tale, Anand, and Gold. I love the fact that we have, dynamic dialogue going on between California and India right now in the session. That's what really makes these sessions just fantastic. So thank you for all the session 2 speakers. And we are now going to transition into session 3. And I'd like to take a moment to introduce Dr. Sudeep Roy, who's going to be the main chair. He's a facial plastic surgeon in Northern California, who I had a chance to overlap with him briefly when he was doing his fellowship here in Austin. Sudeep, it's great to see you. Thank you so much for joining us. Please go ahead and take the stage here with your panel.
Hi, guys. Can everybody hear me?
We can.
Fantastic. Yes. Okay, well, good early morning from here in sunny California. So as Tanuj said, Sudeep Roy, I'm a double board certified facial plastic surgeon, and I'm in private practice here in the San Francisco Bay Area, so Northern California. My practice is largely centered around aging face and cosmetic rhinoplasty, and much like both Dr. Shom and Dr. Nakara, I have also embraced multidisciplinary collaboration through a partnership with an aesthetic dermatologist. So a fun and unique fact about me is that I am actually a singer and once toured with music director A.R. Rahman that some of you might know in the US many years back. I thought that was fun. I would like to extend a special thank you to the meeting organizers, Debraj and Tanuj, for this rather monumental task of assembling so many prominent figures in aesthetics around the world and providing a platform that too free of charge to help disseminate knowledge and foster collaboration. So thank you for that. It's my great pleasure to have been invited to chair the nose segment of this meeting, wherein we will all get the opportunity to get a thoroughly distilled and purified account of some of the most exciting innovations and techniques in cosmetic nasal reshaping, both non-surgical and surgical. My colleague here, Dr. Amit Parani, he's also a fellow facial plastic surgeon from the University of Washington in Seattle. He will be moderating the Q&A session at the end of the lecture series, so please use the avenues provided to submit your questions related to the talks. and we will do the best we can to address them. So, to kick off the session, it is my distinct pleasure to present one of the pioneers of cosmetic surgery in India, fellow Bengali, Dr. Debraj Shom. I think he's the Bengali. It seems like his last name is Bengali. Dr. Shom is not only a uniquely talented and skilled aesthetic surgeon, he is incredibly well-trained in cosmetic disciplines across multiple global regions. Prolific author and a business mastermind, having founded and currently serving as director of the largest chain of multidisciplinary aesthetic clinics in India. Dr. Shom is a fellow of the American Academy of Cosmetic Surgery. He is also board certified by the American Board of Cosmetic Surgery. I could probably spend hours talking to Debraj about his struggles, successes, and experiences with growing aesthetics in India. But for now, I'm excited to hear how he approaches rhinoplasty, both surgically and non-surgically. So let's welcome him to the digital stage.
Hello, everyone. My name is Dr. Debraj Shom, and I currently run the aesthetic clinics in India. The aesthetic clinics has multiple centers in multiple cities all over India. It is important to declare my financial disclosures. I am a faculty with the Allergan Medical Institute and for MERS, which uses or makes the products which have been used in this particular presentation for the past 15 years. Now, rhinoplasty as we know it is very, very important. And as in this young lady who underwent a pen bomb blast injury, you can have the necessity for multiple fractures to be repaired in the face. And then you have to perform an external rhinoplasty for something as complex as this. And therefore, having surgical skills is very important. Now, in this particular lady, you can sort of see the transformation that was created by multiple surgeries which were performed. And you can see we can give her a new lease of life. So I think there are advantages of knowing surgical rhinoplasty. However, we also, as surgeons, we also have to be aware of the fact that there are more and more people who want repeatable, predictable procedures with zero risk. And surgery, as we know, in the best of hands, can have complications. Therefore, the non-surgical nasal rejuvenation is something that is gaining more and more precedence and preference amongst patients. So a non-surgical nasal rejuvenation is one in which we perform a medical procedure with fillers and with threads in order to fill in the depressed areas, lift the angle of the tip, or smoothen the appearance of bumps on the bridge. Now, initially when we started non-surgical nasal rejuvenation, approximately 5 to 6 years ago, we believed that it was an augmentation procedure. So we believed it could not reduce the size of someone's nose. Obviously, you were putting in fillers, so you were adding material. How then could you do a reduction rhinoplasty? But the truth of the matter is, fillers, when used creatively, can actually appear like permanent makeup and can make noses appear, noses can be made to appear thinner using a combination of fillers and threads. And that's what my presentation is all about. However, there are certain cons, obviously. So it helps if you're a surgeon, especially in the thick skin, which is seen in the South Asian and Asian Indian population. It becomes very difficult to really give decent definition with fillers. Results are better in thinner Caucasian skin. And obviously, the biggest con of using fillers is that even though it's a small 15-minute procedure, it will need repetition every 18 months or so. So our choice of filler typically is the Juvederm Voluma. I like it for its high G prime. I also like it for its fact that it causes a great lifting, it has a great lifting capacity, and it provides good structure. We inject it with a cannula, not a needle, and we'll talk about the blood supply of the nose, which can be very tricky. Anesthetize the nose with prilocaine jelly, which 45 minutes prior to the procedure, and then we perform it in the doctor's office, so this is not done under general anesthesia. The con, obviously, is it cannot address every type of nasal issue, so surgical rhinoplasty skills are a bonus, of course. And that's the nasal vascular anatomy, and you should understand that most of these blood vessels of the external and the internal carotid actually go ahead and can cause blindness, and therefore one needs to be very, very, very alert while injecting fillers as well. That's how the fillers are injected. Typically, an entry is made with a 21 gauge needle, and that's a 22 gauge cannula which is being used. And we are sort of passing it just supraperiosteally below the nasal mass, and we are laying out the filler just and molding it with the other hand. So the non-dominant hand is sort of molding it. You can also do it from the top, especially for people who have a depressed or a very obtuse nasofrontal angle. It makes it easy to inject it from the top and thereby go ahead and make the nose appear much more symmetrical and structured. There are also possibilities of injecting it in between the lower lateral cartilages and into the septum, and that way you can actually cause the tip to go up. And by getting the tip to go up, you can actually reduce some of the other problems which are there with the dependent nasal tip, especially one which gets accentuated when someone smiles. These are some of our patients, befores and afters, and I'm very cognizant of time, and I've got 10 minutes, and there's so much to say. But a quick round of befores and afters, so you can see how in this particular patient, the nasal bridge now appears much more defined and shows a far better reflection of light. Ultimately, fillers are like permanent makeup, and that's the sort of definition that you can create. Also, when you look at the basal view, you can see that almost horizontal or round nostrils have now been converted into slightly oval or vertically oval nostrils. So you've been able to pull the bridge up in that sense. It's another patient of mine who came in from another surgery, and she actually has a very big prenasal scar. And in patients like these, obviously performing a flap is something that we could do, but it's a complicated procedure. And what she wanted was actually a little bit of filler. After you've done the filler, you can actually find that the nasal scar actually shrinks in size. So you can see how it's become smaller here. And that's because the nose here overall has become better defined, allowing the skin some leeway over the bone and therefore allowing it to contract back into position. She was pretty happy with the results. That's another patient of ours who's had just a nasal filler rhinoplasty, and those are the befores and the afters immediately after. So you can actually see the injection marks which have been left on the nose. Nasal thread lift involves the putting in of cork threads on the nose. And I know that my colleague Constantine has already talked about this as well. But basically, nasal cork threads have corks all the way around, which sort of engage the SMAS and the nasal skin and tend to pull it upwards. That's how the nasal threads are being put in. And that's a 19-gauge cork thread, which is being inserted both from the lower part of the nose near the tip, as well as near the top of the nose at the nasofrontal angle. And that's the procedure. This is a slightly painful procedure, and obviously bless our patient for being so, appearing to be so comfortable. But as you can tell, even with the prilocaine and the nerve blocks, the patient does feel this a little bit, but this really adds structure to the nose and causes the nose to appear much tighter and far better than just with the fillers. Now that's our patient, and you can see how her nose looks much narrower, and you can also see how the central dorsum of the nose now has a much better reflection of light. That's the side view, and you can see how the nose looks far better on the side view as opposed to before. That's another profile view. That's the base view. And again, you can see the nostrils, which were more circular, starting to become elliptical. We can also use the non-surgical rhinoplasty for the small humps, as in this patient. You can see how the hump has been layered with the presence of fillers, and then we've also used the cork threads in order to tighten the nose better. Now, some patients will have a drooping nasal tip. So you can see how this patient has a drooping nasal tip, which has been treated with fillers both to the dorsum, then also the fillers to the columella, fillers to the pyriform fossa to sort of raise the pillars or raise the base of the nose, and then threads on the dorsum as well. And you can see the difference that this ends up creating. When the patient is trying to smile before, you can see how the angle was between the nose and the lip. And now you can see how the angle is, even when the patient is smiling, the tip is not drooping down, and that's a non-surgical rhinoplasty. You can also use non-surgical rhinoplasty in other creative ways. So that's a patient of ours who had a very flat nasal dorsum. She came in for a rhinoplasty. You can see how the nostrils are almost horizontal. And in this particular patient, we performed a surgical rhinoplasty. But post the surgical rhinoplasty, whenever she put her hand on this particular dorsum, she would say that it's not as smooth as before, which can happen sometimes post-surgery. We decided to layer the top with a little bit of filler. That's how we've done the filler. This is immediately post the filler, so you can see the bleeding points. And that's how the nose now looks. You can see the external rhinoplasty scar below on the columella, but you can see how the nostrils have become vertically elliptical. So you can use it for a small touch-up post-rhinoplasty surgery as well, instead of going in for another surgery. So in summary, it's a good tool to have, and it's something that everyone should know what to do. But obviously, if you have surgical skills, then you can titrate better, because everything cannot be achieved just by fillers and threads in the nose. And then obviously there are different types of nose. You need to take a systematic diagnostic approach and treat every patient in an individualized manner. We love teaching, and that's one of our training courses just coming up. It's a fellowship in facial aesthetics that we perform at the aesthetic clinics. And we encourage everyone to come and learn some of these skills. And we have dedicated ourselves to a lifetime of teaching. And we hope that there will be more people who will take advantage of our courses. I needed to take a minute to talk about one of the sponsors for today's meeting. The sponsor for today's meeting is the QR678 Neo. And as some of you may be aware, this is a formulation derived from a plant base. It's a combination of 6 growth factors and has biomimetic peptides. I was one of the founding team which led to the development of this revolutionary hair formulation. This is administered via mesotherapy to the scalp. There have been 10 plus clinical trials demonstrating efficacy in various hair conditions, which have been published in high impact factor peer-reviewed international journals. Interestingly, in a head-to-head trial, a randomized controlled trial, this was 300% more effective than PRP. This works really well post-hair transplant as well. And this year was a proud moment for us when the QR678 was highlighted as one of the top innovations in IMCAS 2021 and the 5cc Congress. Obviously, this is now being utilized in 10 plus countries at the top skin and hair clinics and with key opinion leaders in these countries. This is also FDA approved in the countries that we are talking about. So thanks to the QR678 team for giving us an educational grant for running this particular educational program. This is a book that we would recommend and request everyone to read. And this is also something which will be given in the gift hampers for the early bird registrations for this particular Congress. This is an anthology which consists of short stories about the doctor-patient relationship. And as doctors, we sometimes face a really tough challenge talking to patients. And there are even instances of violence, physical as well as otherwise, against doctors in various parts of the world. And if you are short on inspiration and you would like to get inspired, read about these 25 doctors in this particular anthology, which has been put together by myself and Dr. Aparna, which talks about all the wonderful things that doctors end up doing and how they are trying to give the human race greater life and energy, especially in this COVID pandemic. I thank you for your kind attention, and thank you once again for having us in between all of you and trying to spread education. Hopefully this talk was interesting for you all. Thank you.
Thank you, Dr. Shom, for a wonderful presentation. Next speaker hails from Istanbul, Turkey, creator of the hugely successful Teo Rhinoplasty Cadaver and Live Teaching course. Teoman Dogan is one of the busiest, most experienced rhinoplasty surgeons in his region. Dr. Dogan is impeccably trained in the surgical arts, having spent time with legendary plastic surgeons Harry Bunke and Baman Gayaran. He is also an accomplished anatomist, teacher, and true technical specialist, well known for his step-by-step guides to achieve predictable, reliable, and long-lasting results in rhinoplasty, which, as we all know, is an incredibly difficult endeavor to master. So we're really excited to welcome Dr. Dogan to share his experience and wisdom with us.
Hi all. Thank you very much for your kind invitation. I hope my voice is okay. Yeah, I will share my screen. Yep. Yeah, I hope you can see. Yeah, I will talk about the tip in my technique, rhinoplasty. I have 5 minutes, so I try to go a little bit fast. So in summary, my technique is about a couple of sutures and one single graft, and it's a kind of a preservation technique. I do a push down for the dorsum, but today I will talk about the tip. And there are 20 steps, some steps are for the tip and some steps for the dorsum. And I have a book that I wrote almost 2 years ago. and sold out like 2,000 now copies. And I do regularly some courses, and my next course is going to be a life surgery course in Istanbul in June 17, 18, and 19. And these are the last days, last week, for the early bird reduced price administration. So let's talk about the tip surgery. In tip surgery, I do 3 things. And I choose a new dome, I correct the resting angle, and I pass from the tripod to a monopod. I will talk each of them. So new dome is, first of all, before starting my surgery, the only plan I do is when the patient is sleeping. I sit next to the patient, and with my finger, I try to find the most beautiful tip shape I can. And then I mark it with my pen, I check it again, and then I mark it on the cartilage with methylene blue with some needles. You can find it in my book. So when I have the new dome during surgery, then the next thing I'm gonna do, I'm gonna change and correct the resting angle. So what is resting angle? Resting angle is the angle between upper lateral cartilage and the lateral crura. And this angle, when we correct it, is narrowed. And in this position, we have a beautiful noise and a noise which can respirate very well. So at the end of all my surgeries, my resting angle is exactly like you see in the video. That means the lateral crura angles are corrected inwards. This is the crucial, most important thing I do in my surgeries. So I have a new dome and I correct the resting angle. So to explain the effect of correction of resting angle, let me show you a couple of photos. For example, have a look here. Here you can see the effect of resting angle, the lateral crura position on the tip of this patient. Same here, this is preoperative, and it's a bulbous tip, and postoperative. I only corrected the resting angle, and the effect is correction of bulbosity, and I have a new tip. You can see the blue dot in my marking. The reason is when we see from the side, we see the lateral crura bulging outside. When we correct it, then the lateral crura now it's invisible and becomes the bulbosity is gone. So let's have a look to this animation that my team member Özkan, he made it. Just try to see the change in the lateral crura's cartilage, inwards, turning, and flattening. We don't have to do anything else to correct the bulbosity. We just have to choose one single dome, new dome, and correct the resting angle. I believe this is the most important thing in rhinoplasty. So let's have a look at another photo. This patient, for example, the only thing I did in the tip is, again, finding a new dome point and changing the resting angle. Here, this is the same. And in this animation, you can see the change in the resting angle and a new dome. That's the only things I do. So how we do these 2 steps? The only thing we need is to put these Gruber sutures. These are hemidomal transdomal sutures, and they will correct the resting angle. And also, we're gonna be choosing a new dome point. And usually at the end of surgery, we're gonna see something like this. The patients are awake after like 1 hour. They are discharged, they are happy, no swelling. The only reason is it's a very traumatic surgery, also for the tip and also for the dorsum. And the third thing we do is using the monopod concept. The reason is actually the tips in most techniques are falling. You know, in my case, my tips were falling for over decades. And so I learned my lesson that I have to do something to prevent this tip falling in surgery. This is the most important part in rhinoplasty. So a natural noise stands on a tripod, but you know, I start to use the monopod. Monopod means the theostrat. It's a new graft. It's kind of an extension graft, if you like, but it has many new properties. So what is new? First of all, it is fixed to the septum firmly, okay? It's very important we fix it firmly. It's an elastic piece of cartilage, it's a triangular cartilage. It's elastic, this is very important. You can move it back and forth during surgery. And then we will take our dome and fix the dome point to the top of this graft. But the only thing we will fix is going to be the dome point. So we're gonna put our figure of 8 suture, and we're gonna use this lines again for fixation. So how we do the figure of 8 suture? We're gonna pass from one side, from the other side, and we're gonna make the 8 suture, okay? And then we have these 2 long lines, and with these 2 long lines, we're gonna make a collar around the graft. And then the fixation is over, and we're gonna put another 2 security suture, so that's going to stay there. So it's simply this. This is the figure of 8 suture. You guys, you were showing very nice things, and I'm showing blood. You know, I love your presentations about the lips. It was great. I learned a lot. Thank you so much, guys. So at the end, I will fix the dome with my suture, and that's all. And when we look the beginning of the theostrat and the end of the fixation, we're gonna see this, okay? So the tip is fixed to this triangular cartilage, but only on the top. Otherwise, it's going to be immobile and the aesthetic will die. Okay, and then we're gonna, when we fix our dome point to the strut, we also can decide our projection. This is very important. So projection and rotation, it's under control. So the rotation depends on the angle of the strut on the septum, and the projection is controlled by the point where we will fix our dome on the cartilage. So it's so simple. So in a 3-dimensional work, we can exactly locate our dome wherever we want to. It's quite new in rhinoplasty, because in rhinoplasty it's a little bit like everything is like flying in there. We are not sure. And if we do this way, and then at the end, our tips are going to be quite soft, which is very important also. I thank you so much all, and I'm looking for the questions, really. Okay, thank you.
That was really, really impressive. Thank you, Dr. Dalgan. I have some questions of my own, but we'll get to them soon. The final speaker for today's session is none other than Dr. Mike Nyack from St. Louis, Missouri. Sadly for us, though, but deservedly for him, he's currently unreachable on a beach somewhere, enjoying some much-needed family time and probably recording some more content for his incredibly well-followed Instagram account, which I think has breached 150,000 followers. A graduate of Yale, Washington University, and Harvard Medical School, Mike may be one of the smartest guys you will ever meet. He is a pioneer and well-respected facial plastic surgeon, specializing in rhinoplasty and aging face, and one of the most sought-out aesthetic specialists in the United States. Although he won't be available in real time to answer questions about his upcoming presentation, we hope you will enjoy what will most likely be a riveting, well-explained talk about his adaptation of the polygon tip concept in rhinoplasty. So you can play the presentation.
Hi, I'm Dr. Nyack from St. Louis, Missouri, and I'm going to give you the 5-minute version of rhinoplasty changes I've made over the last 5 years. I have one disclosure. I do have a video series out for sale, one on deep plane facelifting and one on rhinoplasty. I do get royalties from that. So I first want to say thank you to these surgeons. I'm not going to list them all out by name because I don't have time. But these are the people I learned pretty much everything I know from, plus one other I'm going to mention in a minute. So first set of tips to make surgery go more smoothly and bloodlessly. In 2017, I started using tranexamic acid. I was, I think, one of the first in the States to start using it both in the injection and tumescence in cosmetic or plastic surgery. Prior to that, OBGYN, ortho, oral surgeons were all using it. Now it seems like everybody's using it. It's easily available, it's cheap. I put 2 cc's of the tranexamic acid, so 200 milligrams, into 18 cc's of my normal local anesthetic mixture, and so I get 1% TXA in my local anesthetic mixture. And then the other 800 milligrams I administer IV. I do think it helped decrease bruising and swelling, but what really helped was a few years ago I switched to subperichondrial dissection, and it takes an extra minute to get into the perichondrium, and there's some tricks I'm going to talk to you about in a second. You can actually see this little piece of cartilage up in the rim flap. That's one of the tricks. But this made the most profound difference in bruising and swelling, is switching to subpericondyal dissection. You'll be able to see right up here at the top corner of this pocket, I finally get truly subpericondyal, and I'm going to sweep that and carry that. This is actually from the QMP video series, but this made all the difference. The flap raised is thicker. It is avascular, and the thicker flap camouflages irregularities better. When you come over the dorsum, it's easiest to start subpericondyal right at the midline. That's the best place to find that true subpericondyal plane. There it is. You can see the blue, just like you get blue into the septum. The bare cartilages are also more pliable, and you can use 5.0 or 6.0 PDO sutures. Like many people, I don't use Prolene at all in the nose anymore. PDO is more than enough. And it gives you another layer of camouflage both over your tip and over your dorsum. And it's a more vascular flap. So that's bruising. It's the single biggest improvement I can tell you. Tips to improve aesthetics, Boris Checker. This guy is a genius. And so many of the tips I'm going to tell you from this next section or from this paper, which I encourage you to look up. I think he's the greatest living rhinoplasty surgeon in the world today, and I love that he's got a 3-star review on both Yelp and Real Self, so that makes me feel better about my negative reviews, because he's phenomenal. So as opposed to traditional aesthetics, I'm going to not get into too much detail because I only have another couple minutes. Look into his aesthetics paper, and there are different ways to envision the nose. This polygon concept, I think, is the prettiest. And down at the bottom, the purple, my pointer won't work, but there's something that's shown as the facette polygon. It's kind of by the soft triangle classic description. That is one of the prettiest things. The other thing is in the division between the two domes, the infralobular polygon, the columellar polygon, those are space polygons. They're supposed to be concave, and traditional techniques obliterate that. It's not as pretty. The dome triangle, traditional techniques don't make it triangular. That is not as pretty. So here's what we're going to do. We're going to do an intracartilaginous incision. So we're going to leave a little bit of cartilage up in the rim strip. So it's up in the alar margin. That allows easiest subpericondyal entry. And it's called an auto rim flap. And that part turns down later to become the facette polygon. That already starts narrowing the excess width of the lower lateral cartilage. Then caudal trims and cephalic trims, not just huge cephalic trims. So the auto rim flap takes a millimeter or two. The caudal trim takes a millimeter or two, and the cephalic trim takes a millimeter or two. It narrows the excess width of the lower lateral cartilage in a balanced way, leaving the straightest, flattest central segment intact instead of taking all of the trim from the cephalic. So that's a critical part. So it improves the cranial caudal arc of the lower lateral cartilage. And then we do the traditional lateral crural steal to tension the lateral aspects and then drive all the excess to the medial crus. So how do we do the lateral crural steal and maintain a triangular dome segment? So we do that by using a Gruber suture, and that's a hemidomal suture, and again it creates the narrowness at the superior aspect, the cranial aspect of the lower lateral cartilage, while it preserves the width of the caudal aspect of the dome triangle. And by doing that, we create this pretty shape. It's a triangular dome instead of a pinched rectangular dome, and that actually everts the caudal margin of the lower lateral cartilage, and that opens the external nasal valve. You can see it's got a spring to it now, and again, this is all from the video series, but it gives you a beautiful shape in both the domal triangle and then that spring effect in the external nasal valve. So that's the Gruber hemidorsal suture, hemidomal suture. Anyway, when we've done that tensioning, driven all the excess length in towards the medial crus, we have to accommodate that. That's the medial crural overlap. So again, look up that paper. It describes all these principles in detail. Even better, get his book, Aesthetic Septorhinoplasty by Boris Checker. It's a phenomenal book. This is how we accommodate the excess segment. So now there's no more tension in the tip. It's all treated tension-free. So a tip like this I used to treat with alar underlay grafts and trying to flatten the lateral crus and all that kind of stuff. Now I just do this polygon tip, and it nails even bulbous tips with apparent parenthesis deformities. It's not even parenthesis deformity in real life. We can treat it so much better. So finally, pretty much out of time, spreader flaps maintain width without using up cartilage. A lot of times finding cartilage is the hard part. So spreader flap is good for helping depressed lateral nasal bones or depressed lateral nasal sidewalls without burning septal cartilage. columnar septal extension grafts are my favorite because when we put this graft in, it helps secure the tip position, and it's also basically a bank of cartilage for a future rainy day. Should you come back to revise this rhinoplasty, there's a huge segment of beautiful cartilage right there waiting for you. So I like that much better than septal extension grafts. I have a bunch of other little bits and pieces that I normally go over in a longer version of this talk. And I'm sorry it was so quick, but 5 minutes is 5 minutes. Have a good one.
All right, I guess with that, we conclude the lecture series here. Amit, I'm going to hand over to you.
Sure. Thank you very much, Deep. And so thank you all for those wonderful talks to Dr. Devraj, Dr. Dogan, and actually also Dr. Nak. Unfortunately, couldn't be with us, but I do have a few questions. I'm going to start with Dr. Devraj with regards to the non-surgical rhinoplasty. And one of the questions I have is that, do you have a specific protocol at all? Like, one of the things that I get concerned about when I do any non-surgical rhinoplasty is just the risk of skin necrosis. And do you have any certain tips on how you try to avoid that? And also, if you do feel like you're suspecting that there may be some compromise of vascularity, a protocol on how you address that potentially?
Most of our, thank you for the question, Amit. Most of our rhinoplasties, non-surgical rhinoplasties, have been on patients in whom there have been no flaps, etc., except for the one that I showed in my presentation, where there was a flap and there was a worry of a flap necrosis, etc. These were essentially normal patients. Some of them have been revision rhinoplasties, and we are now at about the 150 non-surgical rhinoplasties mark. But we've never seen too many problems as long as you use a cannula, which I think using it, there was a great paper by Gabriela Casabona, which showed that if you use a cannula, which is 25 gauge and higher, it actually works like a needle. So we prefer to use a 22 gauge cannula, go exactly supra-periostally, stay as close to the bone as possible, and it tends to work really well. We also inject into the columella, which means, again, there is another 21 gauge entry which is made, and then the 22 gauge goes right up till the nasal spine. And so in general, I mean, if you are in the right plane, you don't even have to push your way through too much because it just glides beautifully over the bone. And luckily, maybe we've just been lucky, but we've never seen any cases of skin necrosis or any problems with excessive bruising either.
Okay, that's great to hear. With regards to the thread lift, I found that to be very interesting with regards to the increased tip rotation and things that you do. Do you have certain indications for patients that you would prefer to do thread lift on as opposed to filler? And what is your expected duration of those patients with thread lifts?
So the threads that we use are 19 gauge cork threads, and the cork threads are essentially like the stem of a rose, which have needles all the way around. These corks tend to hold on to the underlying skin and sort of pull it up. And what we would be really concerned about is using these cork threads in people with very thin nasal skin. Because if you have very thin nasal skin, then you could possibly, there is a chance that you could possibly feel the cogs when someone actually runs their hands over the nasal dorsum. But otherwise, the objective of the threads are used as a lifting device as opposed to the fillers, which are more of a filling device. So the lifting device is basically used for those people who have a dependent nasal tip, in whom you want to actually go ahead and actually raise the skin of the nose upwards. In those people, the threads work really well. So patients who have especially the need for some structure, patients who are having a dependent nasal tip which worsens on them smiling, etc., those are the patients in whom the threads do really well.
And have you ever gone back and someone done a rhinoplasty on patients who've had these thread lifts and noted any challenges in the tissue planes or increased scarring at all?
Fortunately, no. There have been 2 patients in whom we've done a rhinoplasty afterwards. How we handle most of our patients now is with the techniques evolving over a period of time. Sometimes it's cheaper and easier for people to undergo a non-surgical rhinoplasty as opposed to getting a surgical rhinoplasty. We all know that noses, especially the ones which have very thick skin, can have a lot of swelling post the rhinoplasty. So a lot of people go for the non-surgical and then go for the surgical rhinoplasty. We've not seen excessive amount of scarring post the threads. However, in the facelifts, in people who've had threads for the lifting the face, there is an increased amount of fibrosis which is seen, and separating the SMAS from the overlaying tissues does become slightly more difficult in the patients who have had facial threads. But in the nose, we haven't noted them, maybe because there's just one thread and that is just below the skin and above supraperiosteal on the nose. And so maybe there was no reason for it to cause increased scarring. But again, the sample size is really small. It's 2 patients in whom it has been done.
Well, thank you for that. That's very interesting results. And well, I wanted to move on to Dr. Dogan and ask a question for your technique as well. And with regards to your use of the Gruber sutures, and I saw on one of your schematics you had like 3 sutures that you used. Do you have any specific tips in exactly how you decide how many Gruber sutures you want to use in a certain area, or the direction and so forth? Just to talk a little bit more about that technique and how much change you get.
Yeah, thank you very much for the question. You mean for the Gruber sutures, right?
Correct.
Yeah, Gruber sutures. Well, you're going to start from the top. It's like about from the dome point. It's going to be like 1 to 2 millimeters. The first one, and then the second one and third one is going to be pretty much close. You should not make a huge distance, because then pitching of the tip is possible. And the sutures should be like first one tight, but the second one less tight, and the third one much less tighter. So that is going to be a capital A letter at the end of your tip. This is very important. If you do it too tight, which is the biggest mistake when I started, I did it many, many times. And then your tips start to get loose, the aesthetics and start to get pinched. It's very important.
And do you notice any? Oh, sorry. Go ahead, please.
Yeah, sorry. One of the important parts, I strongly advise you guys to use 6-O-proline, not PDS. With PDS, you're going to lose your tips.
And yeah, I tend to favor 6-O-proline as well on the tip. And sometimes I even use 5-O-proline. I have very bulbous cartilage in some of the patients here, and with thick skin, I think it's able to hide fine, and thankfully hadn't had issues. When you do those Gruber sutures, do you feel like there's this increased lateral recurve of the lateral crura that you find that goes into the vestibule at all?
Actually, there are many things that I don't believe in, like deformities and problems. Like one of them is the curve, the irregularities on the lateral crura. I think this is not important at all. We don't have to correct it. The only thing we have to correct is the resting angle. Resting angle is like lateral cruras are staying like this, and we have to turn them like this. When you turn them like this, then their surface irregularities, concavities, and convexity are totally invisible. They are not important.
And then one final question. I noticed on one of the schematic that you had, or maybe it might have been the video, in addition to the tail graft, it appeared that you had another inferior graft, whether that was an additional septal extension graft or a columnar strut. But do you tend to combine your tail graft with any other septal extension grafts when you use them?
No, I always do exactly the same things. I only have one single graft, which is tail strut, and I don't have another graft. Only one single graft in my technique.
Teoman, do you do any sort of tongue and groove technique with the medial crura, or you just fixate on the tail strut and that's it?
Yeah, I only fix on the tail strut. I did tongue and groove things, all kind of it for, I don't know, maybe 15 years. And I never, ever do it again.
Well, thank you to you both for the wonderful presentations and results, and also to Dr. Nayak for his presentation as well. And I think that we can maybe move forward after that, unless anyone else has other additional questions.
Well, thank you, everyone, to Sudeep and Amit and Debraj, Teoman, and Mike. This is a really fantastic rhinoplasty section in a super concentrated time frame. So thank you for accomplishing that. And Sudeep, as you're talking, I kind of noticed that you do have perfect pitch in your voice. So your singing voice continues on even as a surgeon. So that's really nice. So I'd like to transition at this point to the lower facelift section of our course, which is session 4. Dr. Daria Hamra is a cosmetic surgeon, oromaxillofacial surgeon, and he is going to take over as the main chair for this session. Daria, thank you for joining us.
Thanks, Tanuj. Thanks for inviting me, and it's truly humbling to be in the company of a panel like this. So I really appreciate the invitation, and Great meeting, by the way, really fascinating. I really enjoyed the rhinoplasty talk, so thank you all the previous speakers. And, without further ado, I want to hand the podium to Dr. Amit Barani. He doesn't need any introduction anymore. He is a facial plastic surgeon from University of Washington, Seattle. So he will be talking about deep plane facelift. It's one of the things that, it's interesting with so many different facelift techniques, so many different smash techniques available out there. A lot of people or surgeons are commonly torn or confused which one is the best technique. Personally, my technique has evolved from smash plication to now deep plane for the past 5 to 6 years. And I'm really curious and interested to see these talks, which mainly evolve around deep plane. So without further ado, Dr. Barani.
Thank you very much for that introduction. And I'll just start beginning to share my screen. And so it's an honor to be here amongst all of you to discuss facelift and also just be part of the panel as well. It's a great learning experience. And, so for my goal today is to really just discuss some key aspects that I found to be helpful in my facelift experience. And so, the success or lack thereof of a facelift procedure to me is directly related to anatomy. And the goal in this 5 minutes that we have is not necessarily to just kind of describe the anatomy as it stands when you're doing a facelift, but to really to correlate certain aspects of the anatomy, specifically primarily the SMAS and platysmal muscle flaps, as well as the retaining ligaments that have really made a difference for me to help improve my results. And so, when I plan out a facelift, I will use a temporal tuft hairline incision, and this shows here the extent of the subcutaneous dissection within the preauricular cheek, and I typically make a line that extends from the lateral canthus to the angle of the mandible to define the extent of the subcutaneous elevation, as well as the entry point of the SMAS for the extended deep plane. And then I'll do an extensive neck subcutaneous dissection as well over the mandible and down towards the midline, in addition to a midline sort of dissection in patients with significant platysmal banding. And then once that elevation is complete, just showing certain aspects to help prevent complications. If you're maintaining your elevation in the subcutaneous plane and avoiding, entering that steep SMAS, you'll avoid injuring certain aspects of the greater auricular nerve, as well as the temporal and marginal mandibular branches of the facial nerve. And to that fact, for some of those participants who may not be as familiar with the specific anatomy of the facial nerve, sort of the deeper aspects, the facial nerve exits the stellomastoid foramen very deep within the substance of the parotid gland, and extends into its superior and inferior divisions. And deep within the gland, it's relatively deep, but as you go more distally, it does extend superficially. And right where you're making your SMAS incision are areas you just need to be careful, because the nerve will be more superficial. Here is the area where I will make my incision. And so when I was taught, I would usually do what we call a lateral SMAS flap dissection. But I've transitioned into more of a dissection that makes the incision more anteriorly and medially to kind of use more of the robust, thicker SMAS and also create a shorter fulcrum for elevation and easier access to the retaining ligaments, which I feel like if I don't release those very well, the degree of tension on my flap and degree of results, are compromised. And to that fact, the most important retaining ligaments that I find are the zygomatic cutaneous retaining ligaments, as well as the additional parotomesenteric cutaneous, and then even along in the more towards the perimedian mandibular region, the mandibular retaining ligament that I'll often release through the midline incision, and just kind of can be correlated, topically, where your pre-genital sulcus begins to form. And here's an example, just correlating a schematic to intraoperative dissection, just showing those mesenteric cutaneous ligaments. You can see here, and they're just little wispy fibers. Once you make that incision, which you'll see in a video just in a moment, you'll be elevating that SMAS flap. And early on, it's very harrowing in the sense of to know the difference between facial nerves and versus the mesenteric cutaneous ligaments, and you'll just feel the difference and just see how wispy. And when I tell the trainees, the fellows, and the residents, anything through which you can see is safe. And so that is the one thing that I will discuss with them. And so here's just a short example of that SMAS flap elevation. I'll mark out the incision, again, typically from that line that extends from the lateral canthus to just behind the mandibular angle. And I use a 10 blade to do the majority of the dissection. You make the incision through that area. And then with the assistant retracting superiorly with the retractor as well as in retracting medially, to really give you a degree of tension is very important. You can see this, the release of the masseteric cutaneous ligaments, and then the autotome masseteric fascia stays deep. And as long as you're above that wispy layer, your facial layer will lie below that. Obviously, in revision cases, it's a little bit more careful because some of that might be disrupted. But you can see here's a demonstration of that protomasseteric fascia underneath. You'll see here like a little facial nerve branch, and as long as you stay kind of within the substance of that loose areolar tissue, it's a pretty safe area, and you can use a combination of the template as well as blunt finger dissection to help really elevate that SMAS flap. My goal is to really release the zygomatic cutaneous ligament as approaching here to find the origin of the zygomatic major muscle. You can see a little facial nerve branch there, zygomatic branch we're pointing out. And then that allows you to also, help release the malar fat pit and elevate that and result in some, volumization of the cheek as you do reposition that SMAS fascia. Just as we move forward, again, releasing more of the masseteric cutaneous fascia, I will extend this, inferiorly into the platysma about 3 to 5 centimeters, and then just using blunt dissection along the inferior border of the mandible, taking it basically to the level of the facial vessels. That just shows you a marginal mandibular branch here that's protected. In additional, these are the masseteric cutaneous ligaments that we're just showing, as we move forward in the dissection. And then as we get much more distal in the flap elevation, the definition of the SMAS layer tends to whisper out, and sometimes I will move forward into a sort of a scissor dissection to help find that origin of the zygomatic muscle at the malar eminence. And once you do find that, we use blunt dissection to kind of elevate superficial to that. And this just shows you there the origin of the zygomatic major muscle, a little bit more of a close-up view. And then we'll continue on. You just got to get a good release from that. And so this is just showing a schematic of, and also just a dissection of intraoperatively. You can see here's the masseteric cutaneous, or the deep protomasseteric fascia that is maintained over the masseter muscle with a little, facial nerve branch here and so forth, just to correlate to the zygomatic that you see there. And just intraoperatively, a patient on whom we just saw the video, just showing that the change that you can expect to see intraoperatively and then postoperatively as well. And so that's just a short sort of kind of pearl of what I find that's made significant changes in my practice, really identifying and making that decision within the SMAS and releasing their retaining ligaments to kind of help get me better results in my practice. So thank you very much.
Thank you very much, Dr. Brani. That was a great presentation. Our next speaker is from Italy, is Professor Francesco Bernardini. He's a US trained oculofacial plastic surgeon, and he's a professor at the University of Genoa in Italy, and he will be talking about endoscopic mid-facelift. Dr. Bernardini.
Yes, thank you very much for inviting me here, and I will talk about my endoscopic experience on mid-face lifting. I started doing this technique many years ago. This is a 2013 publication, but it was much before that. But I want to show you that I don't consider endoscopic surgery as related only to the brow, actually to much lower than that, as I think the most important dissection is into the temporal region, and finding this anatomic landmarks represented by sentinel vein, and lateral to that, the zygomatical fascia and zygomatical temporal nerves on the left side of the patient, this diagram view. And the first phase is the dissection under the temporal branch of the seventh nerve. And after we cross the seventh nerve, and many times we see it, we glide on the SUF level. We make these tunnels, and the first tunnels between the sentinel vein and zygomatical facial will take us into the SUF and lateral between the two nerves. will get down all the way to the mid-facial. And in this, at this level, will be on top of the zygomatical branch of the seventh nerve. So this is the external view of this dissection, and you see that is not really a brow lifting or not limited to the brow. And this is, I want to take a little time on this dissection because here is a nice view of the anatomical landmarks. Here you see the branch, the zygomatical temporal neurovascular bundle and the seventh nerve right on top, originating from just lateral to that. And then we keep spreading with this dissector, vertical spreading of the tissues between the zygomatical temporal and more medially here, the zygomatical facial. And more medially to that, that will be the sentinel vein right there. We make this tunnels and then we can get down with this tunnels all the way down to the SUF and down to the mid face. And all the way medial to the sentinel vein, we dissect the orbicularis retaining ligament. And here the spreading of the zygomatical cutaneous ligament right there is where this can free us the flap for suspension, for much easier and light suspension. Here is the dissection is completely bloodless and in the right plane for malar dissection. I think this is what we get when we get medial to the sentinel vein. We can disinsert, and I think is very important, the lateral orbicularis thickening. Sometimes we do the lateral canthal tendon, depending on what we attempt to do. We can see the intraconal fat. This is the upper lid on the right, the lower lid on the left, and you see between the two fat, you see the canthal tendon. Here is the fat pad that can be even prolapsed and removed. So just to orientate on the cadaver, this is the zygomatical cutaneous ligament release that we do under endoscopic view. Here is the endpoint of the surgery. Sometimes, most of the times, I do associate it with a temporal, frontotemporal complete release and fixation. We're limiting to the temporal malar paracanthal fixation. Here is a standard temporal fixation. I will not spend much time on that. I want to show you the malar fixation using on rubber band needle. This flap is entirely being dissected. So just a 3 microsuture anchored to the temporalis fascia will do. This is the impact of our tension, our fixation here on the mid face, paracanthal, temporal, and I often associate this surgery most of the times with fat grafting. We have proposed the technique called SEFI, various size of superficial enhanced fluid fat grafting, specially designed for the eyes. And then I like to inject nowadays with a cannula into the mid face and very superficial layer. So for results, new fresh results daily on my Instagram page. I want to focus only on temporal malar elevation here. So this is the patient, relatively young, very young patient, is 32-year-old, beautiful girl. She is right 2 hours after the surgery, no scar hidden, just in the face. You see the points where the fixation were made. You see the patient at a week. And this is when at a month, the result a little more so. Here's the patient before and after. This is 6 months post-op. Result only a temporal malar left and endoscopic lifting of this region to show the result. Again, here, there was also a frontal lift here. You see the glabellar elevation there. But the change of the mid-face position is quite visible. Here is a more complicated patient, probably a more subtle result given the impact of the weight of our mid-face. And this is the patient a few hours after the surgery to give you the extent of the dissection we did. And this is the stabilized result in this patient. Other examples, before and after, a year after, again, a year after. And I use this technique a lot in association with canthoplasty for the correction of eyelid malposition, especially cicatricial ectropion. I do associate a transconjunctival approach to dissection of the scars, and all that is about to do there. This is how powerful is the lift through this incision. And again, I use fat grafting in to bolster the eyelid position in the center. This is the patient that you've seen the video where I was pulling the mid-face. This is the day after, and this is a week out. And the final result, a 6 month. There she is. Another patient, this is the side view, the same patient, very difficult to reconstruct the canthus. And this approach made the entire difference for me. This is the patient where I learned the relevance of this temporal malar paracanthal lifting, but especially the temporal approach. The patient was indicating me, I would like to look like that. And I think the procedure really reproduced the result the patient was trying to show me. And that's where I learned it. And then ever since I've been using it, and very successful even in very complicated cases as such. And so for me, endoscopic lifting is just to reposition the entire periocular unit and not just the brow, and especially the mid-face, the paracanthal region with fat grafting, and is especially useful and very effective also in cicatricial ectropion. Thank you very much. I'm giving back to you.
Thank you, Dr. Bernardini. That was very fascinating. Our next speaker is someone who's very near and dear to me as a colleague from the American Academy of Cosmetic Surgery, a fellow maxillofacial surgeon. He really doesn't need introduction as the former president, the past president of the American Academy of Cosmetic Surgery and American Board of Cosmetic Surgery, Dr. Angelo Casalina. Angelo, welcome. And Dr. Casalina will be talking about deep neck lift. And I'm really looking forward to your presentation, Angelo.
Well, thank you very much. Pleasure to have you. Can y'all hear me okay? Hopefully.
Yes, we can.
Oh, great. Okay. Well, I appreciate it. Can you see the screen all right on the deep neck lift, hopefully?
Yes. Yes.
Great. Well, it's a lot to talk about in 5 minutes, but I think it's a great format. I don't have any financial disclosures to go through, but the biggest difference, I think, for me on the deep plane facelift, it really comes down to these more difficult patients versus the easy ones. You know, I mean, we all do facelifts differently, and honestly, someone simple like the ideal facelift patient on the left, you could probably use any type of facelift technique, short plane, whatever, you should get a good result. It's these really difficult patients with the poor muscle tone, the low hyoid, the big submandibular glands, huge amounts of fat, obtuse shaped neck or bone structure. These are the ones we have trouble with. So I'm going to talk about deep plane a little bit in the submental region, as well as deep plane over the parotid, but we've already heard from that. So I'll focus a little more on submental areas. And so the problem with some of these patients that have what I call an obtuse neck or just a heavy neck is there's deep tissues that are causing the problem, and not just this superficial fat that we typically liposuction. So it's this deep fat, deep to the platysma muscle that really accumulates. It's very difficult to liposuction out. Plus you have the redundant platysma muscle, and then often submandibular glands that further compromise these patients with these heavy necks. So I think one of the key points when you're removing deeper tissue, or just simply moving the deeper tissues around, is that you leave this perfect amount of fat attached to the skin. So I'll make an incision posterior to the crease if I'm placing a chin, and then I elevate sharply to leave a little bit of perfect amount of fat all over the skin area. So I'm not doing any liposuction at first, because I think potentially that damages that subdermal plexus. So when I'm doing the dissection, it's sharp dissection, the subcutaneous portion, and I'll go ahead and treat the mandibular ligament at that time with scissors, as you see in the middle picture. it's critical on these big necks to have a fiber optic retractor. I also do endoscopic surgery, so I can use that as well. But this little tongue retractor, this fiber optic, makes this procedure a lot easier. So once you get the skin elevated, then you can address the deeper tissues, and you can do this on someone like this that just doesn't need really a facelift. Most of her problems is down low, so that's no facelift, just skin retraction alone. So what do you do once you're in there and you've elevated the skin? Well, the traditional way of treating these patients is, you clamp it, cut a little fat out of the midline, maybe plicate it. And then some people back cut a little bit. And honestly, I used to do this aggressive back cut, advance it, because that's just the way I was taught. The problem was that really I was under treating several areas laterally, especially on heavy neck patients. I'll still do this technique occasionally with really thin patients. But the heavy neck, here's what I do on them. And effectively, it's removing a huge bulk of platysma. So you're removing all in the midline. The key is don't cut too high up below the mandibular border, because once you cut all this platysma, it's going to elevate really well in the midface. Your jowls will come up easy, but you can overdo it. You want to leave plenty of platysma that'll be along your inferior border. And then obviously you get more access to the submandibular gland if you need to remove it. And you'll find on these heavier patients, when you see this little bulge right here, it's residual little bit of submandibular gland. And I didn't remove as much as I do now to this little area. It does stay pretty swollen for a while. Now, as far as the rest of the face on the deep plane, I do the subcutaneous dissection through the mandibular ligament. And then this is my classic area of deep plane incision right on top of the parotidal mesenteric fascia. But because you've cut out this platysma here, this elevation goes easily. You're not fighting it from an anterior plication. So it's elevation more vertically in the midface region, but really posterior here in the neck area. So two different really vectors once I dissect down, and then I'm simply elevating right off the parotidal mesenteric fascia. And if you see here, let's show a little bit of this video real quickly if it'll play. I'm going to skip forward just a bit so you can see the entire flap. The nice part about a deep plane flap is that it's all in one piece. And so if you're a plicating person, you just like to do a little plication, you'll notice you get some bunching. Whereas this, it's all elevated, it's nice and smooth. So yeah, I don't know if it really works better than maybe a regular plication as far as just lifting a little bit of a jowl, but you get the smooth elevation that you can control really well versus just putting a bunch of bunching sutures from a standard plication. So that's my deep plane in the jowl and midface part of the lift. And it's great for these heavy neck patients, like I said. So aggressive submentoplasty with submandibular gland removal, deep plane facelift over the parotid. I just feel like it's necessary to get long-term results in these heavy patients. They're difficult, challenging, or ones with a lot of extra skin. It helps you, but it's a little nerve-wracking on these big people, because if you look here, this is in centimeters, how much tissue that I'm taking out, but it's the only way I can do it in these really, really heavy patients to get an adequate result. And those are submandibular glands over to your left. I'm only taking off about half of the submandibular gland and then reclosing the cervical fascia over the top. Been doing it for over 20 years. Of course, the first few were really nerve-wracking, and they were probably discovered by accident when I first did it, but now it's really become part of the treatment for these heavy neck patients. And what you'll see to see where the gland is, you'll see sort of a V shape. That's not jowl, that's gland. And so you really can't get this nice, more defined neck without removing the gland in these particular patients, in my opinion. So I think we really only do a few things, in cosmetic surgery. We either make that stuff bigger, we either make it smaller, or we tighten it. It's just sort of picking the right, things to do and make sure we do it very well, smoothly, and with the lowest risk possible. So some of these deeper techniques I think are great, but they may not be best in everyone's hands. Thank you.
Thank you, Angela. This was a great presentation, and without further ado, I'll hand the mic to Dr. Jennifer Murdoch, oculofacial plastic surgeon from Houston, to moderate the Q&A. Dr. Murdoch.
Thank you. Yes, you guys have had some excellent, excellent presentations. You kind of mentioned at the beginning, Dr. Hamra, that people are now moving more mastication into these deeper facelifts, deeper neck lifts. The photos you guys have shown are just incredible. What are some pearls, Dr. Barani and Dr. Kuzalina, that you kind of have when people are considering making that transition in their surgical technique? Kind of what do you think motivated you to move to the deeper plane?
And so I can begin. I was kind of always taught to do the deeper plane, and so and being familiar with the anatomy is the key. And I think it makes you just more confident, and doing head and neck surgery and doing a lot of producectomies. I mean, the facial nerve is pretty well known, and so I think if you're just transitioning to that area. If you have an opportunity to do cadaver dissections and kind of become more familiar with some of the fascial planes, that's fantastic to go to, courses and things. If you don't have as much of an opportunity to do that, when you're making that mass incision, just really being careful. When you're looking at it, basically it's fat up, fat down, and you're in the middle of that white, and that's where the SMAS, that's where the safe area is as far as regard to just like dissecting that deep plane. And just anywhere where we say loose areolar tissue, that's kind of the plane you want to be in. And if you see something that looks like nerve, obviously be very careful. Don't cut it. It's always better to be more careful than be more aggressive. So
I agree completely. Our training fellows learn slowly, but basically what I say is, look, if you don't know where you're at, stop. And so you can, if you're a SMAS placation person, you can easily start slowly elevating a little flap, as long as you know the anatomy really well and you know exactly where you're at. As soon as you feel uncomfortable and you're lost, or you don't know where you're at, you better stop. It's a nice idea to go watch someone get a cadaver dissection, but then watch somebody in person. Hopefully they can mentor you.
Great, thanks, guys. Dr. Bernardini, hi. You kind of had similar techniques to what Tanuj was talking about earlier today, and getting down to that mid face. How often are you coupling that with other periocular surgery and brow lifts? Because it seems like most of your before and afters were also showing that temporal brow lift. And is that something that you generally consider when you're doing an endoscopic mid face, that you might lift that temporal brow a bit?
Absolutely, Jennifer. Thank you for the question. And I definitely did do something very similar to what Tanuj shows. So I think this mid-face lift is adapted to and usable for periocular rejuvenation, because that will help addressing the infraorbital, the eye-cheek junction, basically. So I'm not doing this alone, almost never. This comes many times with lower lip blepharoplasty. This comes a lot with endoscopic brow lift of sort, although much less, I must admit, lately on the frontal part, as my frontalis dissection is being reduced quite significantly these days, and limiting to the lateral 2/3, unless selected cases. But I did start it as a frontal forehead lift, and now is all the way down to, as far down as it gets. It's a superficial flap, so it's not really a deep plane lift. It doesn't require removal of any skin excess, and it doesn't require much more than 2 or 3 sutures, 3 ovicle for fixation to the deep fascia.
Great, thank you.
Well, if there's no more questions, I have a question for Dr. Kozolina. As far as the sublingual, submandibular gland, do you always remove it? And when do you make the decision whether to remove it or suspend it or leave it? Since, preoperatively, it's easy to diagnose that, but once you do your deep plane neck lift and you do the tightening, a lot of times the platysma could suspend the gland itself. So then when the patient is laying down, you can't really assess anymore. So do you just the removal prophylactically? How do you make that decision, or when do you make the decision whether to remove it or suspend it?
That's a great question. If I see that little V shape, I sort of know I'm going to be removing it. But you don't always see that. A lot of times revision facelifts, you see it, of course, because patients had it done somewhere else and they have the bulge. You know you're going to remove it there. Heavy necks, those big patients, almost always I'll end up finding it after I've removed all that deep fat below the platysma. But the average patient, you go in, you're doing your submenoplasty, you don't necessarily see it. And if I don't see it bulging, I'm not going to treat it. So I have to physically see a bulge where I've removed that platysma in that submandibular triangle before I'll address it. Now, realistically, it's probably 80% of my super heavy big patients. And next, it's closer to 30 to 40% of the average patient. But a lot of times when I'm doing the submenoplasty, I won't see it bulging. So I'll go, great, I don't have to remove any gland. I don't really want to if I don't have to. But because I've cut the platysma muscle, when I go back and do my deep plane over the parietal masseteric, I lift all this up. When you pull that platysma really tight, well, now there's nothing below the edge of the platysma. And a lot of times, instead of lifting and forcing your gland up and in, it actually forces the gland out. And now suddenly you see a bulge. And so now you remove it through the facelift portion of your incision. So, which is frankly easier, because once you've done your plicate, you've elevated that deep plane and plicated up, it almost forces that gland a little closer to you. Plus you're closer to the facial nerve and I mean the facial artery. So you can see it, little easier dissection. I just use coag and lift it up carefully and transect it. But there is a little branch of the facial artery there you got to be careful of. But to answer your questions, basically, I remove it when I see it bulge.
Great answer. Thank you. That helps. One question for Dr. Bernardini. Very impressive technique as to the tightening and elevating. How do you determine intraoperatively how far and how tight to make your lift? And then how do you avoid, do you ever see problems with the eyelid function, lower eyelid function, as we see a lot of surgeons doing these cat eye surgeries that have been trending. I've been seeing in my practice a lot of patients with lower eyelid function issues. And so could you comment on that, how to avoid that?
Dear Daria, thank you very much for your question. This is nothing to do with the cat eye. I mean, the one that you're referring to, because the endoscopic cat eye that I've seen, that I'm mentioning, I've seen a complication that I treated over here in Italy, coming from South Africa, and went to somewhere else, having that. They do grasp the canthal tendon, and this is an internal canthoplasty done endoscopically, and then you pull on the canthal angle here, and you stretch the shape of the corner of the eye. By doing that, you alter the balance, and I think they also grasp some of the branches of the orbicularis nerve, of the 7th nerve that goes run through the upper lid orbicularis, giving a temporary, difficulty in closure of the eye. That's the problem that I've seen most of the time in this very tight canthoplasty. And I do not like that kind of eyelid shape. I do not like that. And I tend to, if you've seen, I call it endoscopic canthoplasty, I actually, the canthoplasty is a paracanthal elevation, is right here. I do not touch with the endoscope. So the fixation, depending on what I'm trying to do, are for the brow here. That is my fox eye version, is the exact same thing that I tend to do when I put PDO threads. That's a vector, but that's been discussed before with the patient. So I might want to do a rounder eyelid brow elevation, and I add a paramedian fixation. If I only want to pull the temporal, the temple and the tail of the brow, that is the fixation. Then I want to do the paracanthal elevation for cicatricial atrophy, and then that's going to be another fixation right here. And then I do the canthoplasty through the upper lid and lower lid dissection. For the mid-face lift, I place my elevation point here. But if I've done this dissection with the endoscope all around here, and possibly with an inferior bleph, everything here is free. So with just a 3 ovicle, that's what you get. It's very superficial and light elevation, no skin excess. It will all distribute behind. Like that fox eye technique, endoscopic, for me is something that you do more and more, you get more and more of those problems. And my patient don't want that effect. My fox eye, the way I understand, is about temple and paracanthal. It's not the canthal itself. So
I think one of the great things that comes from having all these great minds speaking together is that if we repeat this meeting next year, maybe Dr. Bernardini, Dr. Kuzulain will come up with the endoscopic submandibular gland resection.
I'm going for it now, yes.
I wanted to really thank the facelift panel and the neck lift panel, Dr. Hamra, Dr. Murdoch, Dr. Brani, Dr. Bernardini, Dr. Kuzulaina. We appreciate everything that you've contributed from a knowledge standpoint. It's a wonderful session. We probably need to have a meeting for every single one of these sessions, just as a full 2-hour or 3-hour session. Now, we are going to transition to the last session in our webinar today. This is going to be the cosmetic dermatology skin session. And I'd like to go ahead and introduce my good old friend Jocelyn from South America. She is going to chair the session. Thank you for joining us, and stage is over to you now.
Well, thank you so much. It's an honor for me. I can't wait to see what they're going to show us. Everything we actually can't do with scissors and scalpels and sutures. So this will be the icing of the cake for this amazing meeting you and Deborah have joined together, and all the world could learn and share. So it's an honor for me to share this session and be able to then talk with Mohammed Banki to then ask all the questions. And we're going to start with Rinki Kapoor, dermatologist, known as the best dermatologist in Mumbai. She trained in the National Skin Center in Singapore and also in Stanford University. So also from the aesthetic clinics, and consultant in the SL Rehanja Fortis Hospital. Please show us everything about acne scars managing. Thank you.
Thank you, Jocelyn. Hi, everybody. It's been a wonderful last 3 hours of sessions. I'll request Dr. Harshal if you can play my recorded presentation. Harshal, are you there? Thank you. Hi, friends. Happy to be here again and presenting to you the pearls of treatment for acne scars. Okay, so I'd like to acknowledge the Aesthetic Clinics Cosmetic Surgery team. Acne scars are a persistent complication with a lot of psychological and physical distress. And these are the pearls of treatment. Assess the type and extent of scars correctly to judge the treatment modality. Active acne must be treated to prevent further scarring. Assess the skin sensitivity, especially if you're thinking about peels or laser therapies. Assess the urgency of treatment. What is the timeline that the patient has? Why does he want to get the treatment, etc. Availability of resources and expertise, whether you have the lasers, you have the equipment, etc. to treat. Explain the expected outcomes clearly and correctly. What is the expected outcome? How many sessions will be required, etc. Patient compliance should be judged, especially for treatments which require multiple sessions, and of course the economic feasibility for the patient. Now, different types of acne scars ranging from macular disease, mild, moderate to severe disease. Severe disease basically are hypertrophic and ice-pick scars which are there. This is how you assess clinically. The first picture, macular scars, no atrophy, no depression, just flat scars, hyperpigmented. The second picture is atrophic scars, has box scar, rolling scar, ice-pick scar. Box scars are punched out. Rolling scars, if you stretch the skin, the scar disappears. That's a rolling scar. And ice pick scars are the tiny but very deep scars which are punched out, very, very deep scars, most difficult to treat. And then you have the keloidal scars in the last picture there, which is different modality of treatment completely. Okay, this is how these scars look on cross section. All of them have fibrous strands which are pulling them down, all the atrophic scars, and these strands have to be released if your treatment has to be successful. Treatment modalities for atrophic scars: if they're superficial, treat with peels, microdermabrasion, needling. If they're deeper, treat with lasers, fillers, surgical techniques, or a combination. If they're hypertrophic, treat with intralesional steroids, pulse dye laser, or cryotherapy. Chemical peels, easiest modality of treatment for superficial acne scars, does very well. Multiple sessions required. Post peel care is mandatory. Sun protection, hydration is what is required. That needs to be emphasized to the patient. Types of peels available: there are so many peels that are available. Common ones are salicylic, glycolic, TCA, and combination peels. Very, very good results couple of sessions down the line. Now, another modality is dermo peel, which is microdermabrasion plus chemical peel in the same session. First do the microderm, then apply the chemical peel and keep it for some time. Very good results for superficial acne scars again. Now, if you have deeper scars like this, you need combination therapies. I'll tell you one of the techniques that we use. This has been published. It was an invited review in dermatologic surgery recently, published by the aesthetic clinics. After starting this modality of treatment, believe me, we have literally cut down, or we haven't had to use surgical modalities of therapy for acne scars. So what this includes is you do subcision, release the scar, and induce collagen. So subcision releases the fibers which are holding the scar down. Hyaluronic acid filler raises the bed of the scar so that the laser can target it better, and also prevents reattachment of the strands to the scar after subcision. And then we do a fractional carbon dioxide laser to resurface and collagen remodel. This is to show you the video. This is subcision. So 26 gauge needle under the skin, break the fibers, use a back and forth or a fanning technique to break the fibers. As you can see here, there's some amount of bruising and edema under the skin, which helps to remodel the collagen. This is how the subcision is done. Then we go ahead and put a hyaluronic acid filler in the same session with a retrograde deposition. I'll show you that as well. So that's the retrograde deposition in the same session right after the subcision. Okay, so that's filling up the scar and also will prevent the reattachment of the strands which have been released after the subcision. And thereafter, this is the appearance of the space immediately after this. Then 1 week later or 2 weeks later, you do the fractional carbon dioxide laser. Number of passes depend upon how severe the scar is. You need multiple sessions. This is the fractional laser which is being used. That's a fractional beam, so you cover the entire thing. Multiple sessions of this laser, typically at 6-week intervals. Look at the fabulous results that you get with this combination therapy. This is a very severe grade acne scarring. Look at the results. Combination of subcision, filler, and fractional carbon dioxide laser. These are the results, okay? And very, very deep and ice pick scars, you have to use a technique called as TCA cross, wherein you stretch the scar, dip a toothpick in TCA 80% or 100%, go to the depth of the scar, deposit the TCA, get immediate frosting, then you have scabbing, and then the collagen remodeling starts. Typically, you can do this particular technique, say about once a month to give you good results, and then you can combine the lasers thereafter. So that is a treatment for deep ice pick scars. So these are the pearls of therapy in a nutshell. Assess the scars well for you to judge what treatment is required. Prevent active acne recurrence. So treatment of active acne is extremely essential. Combination therapies generally work better in atrophic scarring. Oral isotretinoin low dose has been found to be very effective in collagen remodeling and treating acne scars. So along with these therapies, if the patient is on low dose isotretinoin, typically 10 milligram thrice a week is what we do, it gives a very good result, and I found it to be really, really helpful. Of course, anti-scarring creams should be used. Post-procedure proper skin care is extremely important. Please emphasize this to the patient. Please take regular photos for documenting the improvement over serial sessions, and explain the requirement of multiple sessions and the expected outcome clearly right in the beginning. Thank you so much.
Thank you so much. Those are amazing results. It really it's really amazing. So I'm sure everybody has a lot of questions, but let's go with Altuk Santillaya. He's trained in Cincinnati by Bob Kirsten and Dwight Codowin. He's a big contributor in the several American, European, and Turkish societies. He's a member of and leads courses and meetings all around the world. He's currently in his solo practice and also a teaching professor in the University of Kusef in Turkey. So please, Altuğ, you can start your presentation.
Thank you so much, Jocelyn. Let's start the last talk of the 3-hour run. And let me share my screen. Okay. So Tanuj and Debraj asked me to, mention about my techniques in non-surgical skin tightening, which I think is a major issue because, as elegant surgeons, we always bring our surgery to the best. And then there's so much we can do, but we cannot correct the skin texture with our surgical abilities. So I have no financial disclosures about what I'm going to talk today. And there are so many ways that I use to adjust the skin, but I will mention 4 of them, the ones that I use the most. And let's start with the plasma technology. Well, this is a pretty simple device, and I very rarely use it for an upper blepharoplasty kind of treatment like this. But what I usually do is I use it for postoperative adjustments, like I did in this young gentleman, where I did a good ptosis lift. He was a congenital ptosis patient, and this is a good result surgically. But although I gave him a good crease, which he lacked, it is not as symmetrical as I wanted. So postoperatively, within a few minutes, using the plasma device, I could just adjust the creases for a more symmetrical result. And so this is a patient. I did a lower blepharoplasty, and he's happy, but he says, okay, can't you just correct this? And yes, yeah, I can, simply without taking him back to the OR. And this is a much better looking lower lid skin, which gives him a happier result. So I've been using radio frequency devices for over a decade, and now my final best is the RF microneedling, which combines the radio frequency with the microneedling we used to do a decade ago. We are able to deliver the heat directly to a programmable depth, and we don't cause any epidermal damage, and we use the fractional capabilities to heal much faster. So this is the Morpheus device, which can easily coagulate the fat deep underneath the connective tissue, contract the connective tissue, and heat the skin to a subnecrotic level, which is very easy to heal. There's no downtime. And this is a patient I treated 3 or 4 years ago. She was 78 at that point, and she didn't want to undergo surgery, although I insisted. She said, yeah, do something that will make me look better. So I tightened her skin, and this is a 6-month result she was quite happy about. And Morpheus is especially good with no fat underneath the skin, but a lot of elasticity loss, like wrinkles, collagen loss, and not much fat, but some bulging underneath. So we can get rid of these lines and wrinkles for at least a year or 2. And with the bipolar RFs, namely Actite and FaceTite I use, I can pretty much tighten the whole face. I can do brows and upper lids and lower lids maybe, or skip the lower lids, but I can tighten the whole face, including the lower eyelids, the nasolabial fold, the jaws, and the neck with this equipment in my office. The main target of these devices is the sub-Q tissue, the fibrosepta network, which shrinks by heating the subcutaneous network. And this is a patient with a 6-month result who is quite happy without surgery. On the right side, actually, she had a terrible filler complication elsewhere, and this area is whole fibrotic tissue and nothing else. So with that bipolar device, you can actually carve out the fibrotic tissue, apply heat, and tighten that area. And take a look at this patient, which is quite difficult to treat, this orbicularis roll. And there's a significant asymmetry with the right side and the left side of the face. And 4 months after 1 session of Actite and 3 sessions of Morpheus, I can achieve a pretty good result, which I wouldn't be able to with fillers or surgery. So the FaceTite has a mode called a radio frequency assisted lipolysis. It doesn't melt the fat, it shrinks the fat. Dr. Casaluna showed excellent results on these very heavy necks. And when they don't actually want surgery, we can go in and shrink the preproximal fat and all the subcutaneous tissue along with the skin, and the final result is still sustained at 1 year. This is not a perfect result, it's her surgical result, but for non-surgical patients, it's good enough and it's sustainable. Okay, let me see. Why can't I move forward? Yeah, okay. Now, among all the injections I use, I just want to show you one of my favorites. Endopeel is for the lower face. And for the lower face, actually, this works on the muscle tone. And there's a certain patient selection criteria. You shouldn't have a lot of fat. Very little fat, saggy skin. The patient can be young and old, it doesn't matter, but a very good bony structure is a must for these patients. And you can see the immediate result right off the table, and the results are sustainable for 9 months, and they always want to come back because the endopeel also reforms the skin texture. It's an inside-out rejuvenating capacity, and she seems to have at least 3-4 syringes of filler. She didn't have any fillers. The whole effect, including the under eye effect, is maintained by the endopeel. And one last thing I use recently is the stromal vascular fraction for patients like this, because no matter how much I do an incredible surgery, I cannot correct this. This is a whole collagen issue and skin issue. So what we do for these patients is go in and take out some liposuction fat, and then apply some collagenase and apply some other stuff to get the stromal vascular fraction, which includes the exosomes. Debraj is a big fan. He will tell you for the hair loss. And now it's pretty simple. Right after the surgery, you just inject it to right underneath the skin, intradermally and supradermally, with the cannulas or with the needles to the points where you want. And the final result, the 3-week result is even as good as the 1-year result. And you wouldn't achieve this kind of result for the skin with surgery only. So you have to get some supplements. And this is a lady who refused to have surgery 3-4 years ago, and then finally decided that she should undergo surgery. So I transposed all the fat and lifted the mid-face, but the skin texture, since she's over 80 years old now, and the skin texture is only doable by non-surgical options. And the stromal vascular fraction, this is a month after surgery, stromal vascular fraction gives the skin a lot of healing. So that's all I want to talk about today. And you can touch up on Instagram and shoot me any questions if you like to. Thank you for listening.
Very interesting options, Alto. Very, very interesting. Very innovative as well. So thank you. Thank you for sharing. So Dr. Banki, do you want to do any questions?
Yeah, actually, I have a somewhat related question, and that pertains to use of Accutane or isotretinoin. Clearly, the skin envelope plays a huge role in lots of cosmetic surgery procedures that we perform, and in particular rhinoplasty. And I just wanted to get your opinion whether or not you've ever used it prophylactically, not so much for use in treatment of acne, but in individuals with thick skin to sort of thin out the tissue envelope prior to performing a rhinoplasty or a procedure that would be perhaps masked. The extent of this good outcome would be masked by the thicker skin. Any experience with that?
Any of our rhinoplasty surgeon colleagues can quote about that experience?
Sorry, but can you repeat that question? Sorry, I apologize. I didn't hear.
No, it was just more of a question. It could be a derm or it could be rhino, but just the question of use of isotretinoin or Accutane to thin out the skin envelope prior to performing the rhinoplasty. Individuals with very thick skin that perhaps
there are some patients that we associate with rhinophyma and eczema rosacea that have been treated. One of my colleagues in South America she uses a lot of it, and I have not personally used it, but she's found success in a number of her patients using it. And so you just have to be, I think, really careful with that. And the dermatologists probably have a much more experience with using isotretinoin, and I don't feel as comfortable yet, but she uses it very easily and it's within a low dose, I think, and has success with the results she showed.
Yeah.
Dr. Rinki, do you want to comment on that?
Yeah, so nothing specific to rhinoplasty, surgical rhinoplasty as such, because I don't have any experience regarding that. But in general, isotretinoin, I think, is a wonderful drug if it's used appropriately. And we use it in and out for acne, for treatment of active acne. We also use it a lot for treatment when we are treating patients with acne scars. That's what I had shown in my presentation as well. So I think initially there was a lot of hindrance in using it because there was a guideline mentioning that you need 6 months of time after you stop the oral isotretinoin before you do any procedures, whether it's a surgical procedure or whether it's a dermatological procedure. But then now the things are slowly changing, and now we are doing procedures even on patients when they are on isotretinoin. So the only thing you need to be a little careful is that the patient shouldn't be on high dose isotretinoin when you're doing dermatology procedures or surgical procedures. But low dose isotretinoin is actually, it's been found to help and aid in better results of whatever procedures that you're doing, especially for acne scars. I think 90% of my patients whom I'm treating for acne scars are on low dose oral isotretinoin if there are no other contraindications for them. And I think it works brilliantly well.
That's excellent answer. Exactly what I was looking for. Is very consistent with the literatures out there. Just wanted to confirm that.
And Dr. Bunky, we also use it as an anti-aging medicine. So in a lot of patients who look for improvement of fine lines and they've got a little oily skin and things like that, if you judge correctly, you can also put them on 5 milligram alternate days kind of a thing of oral isotretinoin. Has been found to improve the glow, the brightness, the shine, and it really works. I mean, it's wonderful if you use it correctly.
Thank you. Excellent.
There's actually a question for Dr. Alto. Jocelyn and Dr. Bunky, if you don't mind, I'd like to ask him that question. And the question for you, Altug, is can you actually avoid an upper blepharoplasty by using the plasma pen?
No, actually, yeah, at the beginning of my talk, I said no, because, you know, there are several dermatology colleagues of mine that are big fans of medical aesthetic people, but I very rarely use it for an upper blepharoplasty. I mean, maybe once or twice every year, if there's only a little bit of excess skin with no subcutaneous, you know, prolapse or fatty prolapse. Yeah, those guys may be candidates. But, you know, the problem with this is it takes more to heal compared to surgery. And, you know, it is effective for only a few years. And finally, if you keep repeating it, there's a few colleagues that really just kick the hell out of the skin, and you know, they give very permanent pinkish tone difference, which I really don't like. So I don't approve the use of the Plexer or the plasma pen for a large, you know, blepharoplasty purpose. So the answer is no, but it is extremely helpful for minor adjustments after your surgery, or some removal of the tiny bit of you know, lumps and bumps, especially in the eyelid margin.
Excellent
yes, I actually own a device as well. The company gave me one, and I permanently see complications come into my office. Practitioners use the device in the thick skin around the periorbital area, and I see very, very complicated cases of scarring. They do actually go all the way through lines, and I see retraction, We have in Latin America darker skins of all the colors, and there is decoloration, hyperpigmentation. So I would recommend only to do it in the very thinner skin and very white, fair-skinned patients. And also very limited to the upper eyelid, not to the lower eyelid at all. I think it's also, it swells a lot. It hurts in my hands. You do need to use local anesthesia. So I would rather do a very conservative, nice designed upper blepharoplasty in the office than to have a, healing with a lot of inflammation during 2 weeks. I think the downside is not comparable. And then I see a lot of patients having filler and then this procedure, and the inflammation is awful. So not recommendable in oculoplastic point of view.
Thanks, Jocelyn. I had a question from the audience for Dr. Milind Naik. Milind, are you there? Milind, the question is, do you ever do skin-based lower blepharoplasty? And since you seem to prefer transconjunctival bleph, how do you address excess tissues of the lower eyelid skin if that is indeed the case?
Yeah, hi Debraj. I would prefer to go transcutaneous if there are a lot of static lines in the lower eyelid, which means the skin is obviously excess, and if I remove fat alone, then that skin is going to throw into more wrinkles. So that kind of a case, I would go transcutaneous. Otherwise, I would prefer to do a transconjunctival. Although I warn the patient that the wrinkles could increase mildly, and if it is a bother, we can always do a skin pinch later.
Thanks, Milind. It's my distinct pleasure to also welcome Dr. Namrata Sharma and Dr. Rajesh Sinha now to this particular Congress that we are conducting. Dr. Sharma is the Secretary of the All India Ophthalmological Society. That is 25,000 plus ophthalmologists all over India. And Dr. Rajesh Sinha is the treasurer of the same organization. The AIOS is one of the collaborating organizations on this particular Congress, and the lady and the gentleman were in transit at this moment, till this moment in time. And at this moment, they're traveling as well, but connecting to just say hello to everyone. Dr. Sinha, Professor Sinha, Professor Sharma, over to you.
So thank you, Debraj. I think you've done it again. Last year, again, we had a very big summit of the cosmetic surgery, and this year again, with so many societies involved from all over the world, we have close to 1,500 plus delegates from 40 countries, as you have put out on the information. And we are very pleased to welcome all of the societies who are involved in this. And I think it's a real, it's something which everybody has to learn from, because so many multi-specialities across the entire medicine and surgery have gotten together today to give a holistic approach. And I think both Debraj and Tanuj have really designed the program really very well. Aesthetics Masterclass, which is a 5 minutes Pearls medley, and all the societies are involved, including their leadership, which includes the SOP, ANOP, AACS, ABCS, CDSI, ASOPS, AFPRS, and All India Ophthalmological Society. So it is our pleasure and our honor to be involved with so many societies at the time. And it was a pleasure. I did hear a couple of last talks, and it was a pleasure to hear those non-ophthalmological talks and know about the cosmetic surgery. So thank you so much, Dr. Debraj and Dr. Tanuj, for doing it. And I'm sure we are going to have yet another platform after this involving the cosmetic surgery. So keep the momentum high, and we are always there to collaborate. Thank you so much.
Thank you, Dr. Sharma.
Thank you, Dr. Sharma. Really much appreciated.
Professor Sinha. Professor
Yes.
Sinha.
Yeah. Thanks, Dr. Debraj. It was really, unfortunately, we could not attend the whole of it. I was, we were traveling, but the later part of it, which I could apprehend, which I could understand, is some very interesting discussions were going on, some interesting talks. And I believe that facial aesthetics is such an important thing, which, changes the life of an individual. It changes the personality. It, improves the well-being. So, the quality of life. So you guys are doing fantastic job, and I would like to congratulate everyone and thank everyone for joining in hands with AIOS. And I would like to thank Dr. Devraj for taking this initiative in having so many societies together and doing this fantastic webinar, which I'm sure Dr. Devraj has trained so many people in facial aesthetics over here. And with these webinars, with these informations, a lot of people will have more and more, it will generate more and more interest amongst the, oculoplastic surgeons and among the facial aesthetic surgeons. And for that, I would like to thank you all, especially Dr. Devraj. Thank you very much.
Thank you so much, Professor Sinha. Tanuj, over to you. Thank you so much.
Well, the last few hours has just been terribly fun for me to hear all these lectures. What a treat to get concise pearls from masters around the world. Everything has changed when it comes to academic education and international collaboration. And from the darkness of the pandemic, there have been some lighter situations, and I think the willingness and enthusiasm for online webinars is one of the benefits that has occurred. Everyone knows how to use Zoom now, and it's just a lot of fun to interact with people around the world in real time and share ideas. So I want to thank everybody. The recent group with Jocelyn and Mo and Rinky and Altug, thank you so much for a wonderful skin session. We look forward to more meetings like this in the future, both on a general cosmetic surgery sense, but also focal meetings in the future. So stay tuned. The best way to keep up with what we're up to is to follow Global Cosmetic Surge on Instagram and on Facebook. We will continue to have these meetings into the future. It's just been a wonderful morning for me here in the central time zone of the United States, all the way to, I think, the furthest east was Tuan Pham, who's probably getting close to midnight in Australia. So on behalf of Debraj, myself, Monica Sarana, the rest of the Global Cosmetic Surgery team, we appreciate you. We bid you adieu for now. Thank you very much.
Thank you.
Thank you, everyone.